Check 1, 2. Okay.
Where do we go? No, for 2 minutes? I can do it here.
So you want to go with that?
Yeah. Good morning. How do you advance slides?
A lot of sunlight, they're all off.
No, how do we?
Scroll forward.
Yeah. Good morning. Good morning, everybody. If everybody can take a seat. On behalf of New York Medical College, I'd like to welcome everybody. My name is Salman Amar, and I'm very pleased to see this room being filled up, which is a testament of the commitment of this community towards a space that is being investigated by numerous individuals. We see almost 700 papers on PubMed every month associated with one way or the other in the microbiome. It was coined by Lederberg and Mackay in 2001 as the ecological community of commensal symbiotic and pathogenic microorganism within the body space as well as other environment. There's a microbiome in a sewage system. There's a microbiome in water. There's a aquatic. The sea level is populated with the microbiome. The microbiome is not solely associated with the human body. They are community. It's a community of microorganisms that exist. It is defined as a collection of microbe, bacteria, and viruses, millions and millions in a magnitude of 10 to 1. We are just 10, a tenth of the number of microorganisms that populates us. Each person is made of multiple ecosystem, and as such, each individual microbiome is composed with a diverse collection of microbiome. Um, we ran, and I'm not a microbiologist, I'm an immunologist. I became somewhat associated with microbiologists, given my involvement with the oral microbiome. Um, the biggest problem that we had in this space is that only a certain number, a limited number of microorganisms were able to be cultivated, and a vast number of microorganisms were called the non-cultivable microorganism, and that was a major issue that we faced until the metagenome and until the 454 Illumina platform, etc., that came and helped us into identifying non-cultivable microorganism, as well as generating new information. So who are we? Basically, as you see from Martin Glaser's paper in 2010, we are just the leg of an individual in terms of the eukaryotic cells. This is just the leg 10 to the 13th, as opposed to 10 to the 14th, an order of magnitude of 10 differential. So as such, they're populating our body, and we having the importance of understanding where we stand with what are the identity, that's the plain and crypt element. What are those microbes doing? I doubt that they're just there to play chess or a game. How is the host parasite interaction being and maintaining this microbiome together? How is the host responding? What are the forces maintaining the equilibrium? There is an equilibrium between the microbiome and the host, and when it tips either a number or in virulence, then you have a disease that is emerging. And what are the unique characteristic of each individual when it comes to the microbiome? Here you have some of the facts that are so important to remember. Um, and I'll read you just the last piece. By harnessing this untapped potential of the microbiome, the next generation of therapeutics, and you'll have an opportunity of listening this morning from experts in the field, therapeutics that may capitalize on the use of the live microbiome and microbes, specific metabolites generated by the gut microbiome. We're using right now some of the gram-negative microorganisms present in the GI tract that improve obesity, that improve diabetes, that improve my profession, gum disease, that improves bone loss, and on and on and on. But just like the genome, when we had sequence, and I was privileged to participate in the genome project, when just like the genome, everyone's gut microbiome is unique, and we cannot make a big generalization, so that what's good for an individual may not be so good for others. And you'll hear also by some of the industry that are present today. This is the program, very interesting speakers, spanning somewhat, and we cannot be so comprehensive, but spanning somewhat this space of the microbiome. So I hope you'll enjoy the presentation. I enjoyed inviting them, so I'm sure that you'll participate with me. I'll be remiss to not to mention that our administration, without them, we would not be having those conferences, and mainly, specifically, the different people that I invited this morning to address and to give you words of welcoming statement to this. A wonderful man at the helm of this institution that has been giving us the courage, giving us the enterprise, giving us giving us the foresight to put and to improve the research enterprise. Alan Kadish is the president of the Truro College and University System. He has given us as a contamination now in the realm of microbiology, contaminated with the virus of being always and trying to be greater and push the boundaries so we can do better and we can inject into this environment uh, interesting concept. One of them is the microbiome that we do. He's an academic cardiologist, very well versed, well published, and he has taken this university to new level. Without any further ado, please join me in welcoming Dr. Kadish.
Uh, Welcome, everyone. I'd like to thank Dr. Amar for organizing this, the speakers for coming to join us, as well as everyone for attending. Um, as Solomon mentioned, I'm a cardiologist. I know very little about the microbiome, so instead of trying to talk about it, I'll leave that to people who are the experts here, and I'm going to tell you a personal story. Um, my mother was an interesting woman. She was born in Vienna in 1921 and passed away just a few years ago at age 90. And in many ways, she had a very successful life. But she also had a very tough life. And she had a tough life for two reasons. One is being 17 or 18 years old in Vienna at the time of the Anschluss and having her life upended took her about a decade to recover from until her family settled in the United States. But the other reason, and the reason I'm telling you the story, is for 50 years, my mother suffered from abdominal cramping and diarrhea. She saw the greatest experts on gastroenterology around that time. And the reason I'm so familiar with some of that is many people have bonding experiences with their parents uh, because they've gone to museums and they've gone to the beach. And sure, we did that. But my bonding experiences with my mother were going to see Dr. Janowitz at Mount Sinai, who was considered the leading gastroenterologist, clinical gastroenterologist of his generation, and going to New York Hospital, where the New York City ova and parasite analysis laboratories were. And of course, every diagnosis she had, from irritable bowel syndrome, for which she was treated with steroids, to unculturable parasitic disease, every diagnosis was wrong. The curious thing is there was only one thing that made her a little bit better: eating yogurt. And so there's no question in my mind that she spent 50 years suffering from gastrointestinal derangement of the microbiome, some of it related to food intolerance, but some of it related to probably what we're going to learn about today. And interestingly, all the trials of antiparasitic medication or other drugs probably made things worse by destroying her gut flora. So, on a very personal level, I'm thrilled everybody is here today to try to see what we've learned, and maybe in the next generation, in addition to not having an ounce loss, we also won't have gastrointestinal disease due to disorders of the microbiome. Thank you all for coming.
Thank you, Dr. Kadish. I'd like to call upon our Chancellor of the Chancellor of New York Medical College. He's a pediatric radiation oncologist and historian. He'll tell you if you stay after hours, beautiful stories of histories. He's a fascinating person, a telltale. Uh, he has been since 2012 at New York Medical College and has taken the college from a step to another one. An experienced academician, an experienced administrator. He has given us light to being able to continue to provide leadership into this environment. He has published numerous papers. Among one an important aspect is he's the author of the sixth edition of the Principle and Practice of Radiation Oncology, authored more than 210 papers. um, I'll leave it up to you to appreciate Dr. Halprin. Please join me in welcoming Dr. Halprin.
Thank you, Solomon. Thank you for inviting me. It's going to take me a while to recover from Solomon's slide. What are they doing there? Playing chess? And that the microbiome includes not only our gut, but our skin. So I'm thinking, considering how bad my chess game is, how many potential grandmasters did I wash off myself in the shower this morning? Could I have used their advice? I'll be more careful now. Perhaps I should ask them to raise their hands if they have a certain chess rating when I take a shower in the morning. And God knows what I'll think about when I go to the bathroom now. Um, I want to talk with you for a minute about why are we really all here? Why are we really all sitting here in this time and place? Uh, Most people will say that the greatest writer in the English language on higher education of the 19th century was Cardinal John Henry Newman, whose most famous book is called The Idea of the University. There is more of a debate about who the greatest writer is on higher education in English in the 20th century, but I am a defender of Robert Maynard Hutchings. Hutchings became the dean of Yale Law School when he was about 27 years of age, the president of the University of Chicago by the time he was 28 or 29. And he is one of those famous people that now almost nobody ever heard of. Sort of like the founder of this college, William Cullen Bryant, famous in his own time, but now generally lost to our collective memory. I am a Robert Maynard Hutchings addict, and I want to tell you this morning about his 1929 commencement speech at the University of Chicago. He was at this point the president of the University of Chicago and a grand total of 30 years of age. A university, he told the assembly, is not a collection of buildings, nor a collection of books, nor even a collection of students. It is a community of scholars. The first duty of a university is to provide those scholars with a means of life and the means of work. If young men and women then wish to associate themselves with the scholars, they must do so on the scholars' terms. They must have an abiding interest in the things the scholars have to offer them, together with the minimum intellectual equipment necessary to understand those things. There's another version of Hutchings' commencement address, which was given by H. Keith Brodie, who was, for a time, the president of Duke University. And what he wrote was, "The university is a community of scholars. It is not a social service agency. It is not a real estate development company. It is not an insurer of large scale employment. It is not an entertainment or sports entertainment complex, although many people would wish it to be those things. What it is a community of scholars." So, you have gathered this morning as a community of scholars to talk about the generation and conservation and dissemination of knowledge about the causes, prevention, and treatment of human disease and disability and its relationship to the microbiome. You have, therefore, fulfilled one of the missions that Hutchings set for a university, a place to allow scholars to go about the means of their work. And New York Medical College is delighted to host you in this work. You have honored the college by your presence, and I wish you Godspeed in your deliberations.
Thank you, Dr. Halpin, for those very inspiring words. Um, Recently appointed at the helm of the medical school, Dr. Jerry Nadler is the dean of the medical school. It gives me a tremendous pleasure to bring him to the podium. He's a member of the special, he's a diabetic researcher and endocrinologist, an expert, world expert in type 1 diabetes, and hence the importance of the microbiome with diabetes as we see today. He's been a standing member of the American Diabetes Associated, American Heart, NIH Study Section, and so on and so on. His accolades have been described in many publications. He is has his work has identified inflammatory pathways leading to pancreatic beta cell damage, insulin resistance, and atherosclerosis. He his research was funded by the and is continually funded by the National Health Institute as well as the Juvenile Diabetes Foundation. And the current work is designed to determine whether viruses could trigger type 1 diabetes. Please join me in welcoming Dr. Jerry Nadler.
Thanks, Solomon. So I'm the last speaker keeping you from the science, so I'll be relatively brief. I'm the new person on the block. I want to thank Dr. Amar for putting on this wonderful symposium, all the audience and the speakers, and the wonderful words. I'll give you a couple of thrilled to be here at New York Medical College at the helm of, as Dr. Amar mentioned, I'm a physician scientist. Research is one of the major missions that we have here at New York Medical College. And I feel that research helps our education mission and will help our clinical mission, and they all roll together. I'll give you a couple of short vignettes about, I'm a simple diabetologist, about the link between the microbiome and diabetes, but also a personal connection that I just got back from Peru, Machu Picchu, and the Galapagos, and I can tell you the microbiome does affect when you change microbiomes. I won't go into the details, but people that have traveled know that your travels do affect your microbiome very quickly, and then hopefully you recover. But a couple of vignettes about microbiome and diabetes. As Dr. Amar mentioned, number one, it turns out that there may be a clear link between viral infection and development triggering of type 1 diabetes. Whether that's a direct mechanism or whether it's affecting the bacteria, whether it's affecting other inflammatory pathways, still has to be decided. That's number one. Number two, I'll give you a unpublished information. I know one of our speakers is from Jackson Labs. This is a very interesting connection with that. Turns out that one of the mouse models that people use worldwide to study type 1 diabetes is the NOD mouse. It develops spontaneous type 1 diabetes. It's a great model as far as a mouse model. About 70% of the female mice will develop spontaneous type 1 diabetes in most labs, in most vivaria across the country. So at Eastern Virginia Medical School, where I came from, we wanted to study the NOD mice. And we ordered them, but we couldn't study them. You know why? Because almost none of them got type 1 diabetes at that vivaria. We said, well, maybe there's something strange. So the same order we sent to my collaborator at Indiana, and we had them at Eastern Virginia Medical School. Indiana ones got spontaneous diabetes at the rate they were supposed to. The ones at Eastern Virginia Medical School, 10% rate. We couldn't do the work. We had to collaborate. And we did some studies, and it turns out the microbiome was different. Was the appropriate microbiome at Jackson, but within 3 or 4 days, it changed in the vivaria. So that's a little warning and understanding for people that are doing mouse-related research. And the NIH reviewers know this now, that when you have even one room to another, we talk about skin, but you talk about one room to another in a vivaria, or one vivaria to another, may be completely different results. And it's all related to the microbiome. That's number two. The third one is clinical. And I assume some people might have diabetes, and one of the common medications for type 2 diabetes is metformin. It's not proven yet, but there's some suggestion that metformin, one of the mechanisms of action, is on the gut and changing the gut microbiome. And so that's a medication that many people take, the number one medication for diabetes that may work through the microbiome. So I don't care what field you're in, you're doing a mouse research or a basic researcher, you're a clinician, this field is exploding and very, very important. So I'm thrilled that Dr. Amar set this conference up. You're in for a treat, and we're wonderful. I'm glad to be here at New York Medical College and being at the helm of the medical school to hear this wonderful symposium. Thank you very much.
we're glad that you came to us, Dr. Nadler. There's plenty of time for question and answers during the program. Please don't hesitate. They're not a stupid question. They're probably stupid answers in my book. Our first speaker is Dr. Harry Greenspan. He's an assistant professor at the Department of Medicine in the Division of GI Microbial Therapeutics. He received his medical degree from Albert Einstein College of Medicine in New York and completed the internal medicine training. Dr. Greenspan pioneered the fecal microbiota transplant known as FMT program to treat recurrent and refractory C. diff, Clostridium difficile infection at Mount Sinai, which is an important aspect. His research focuses on exploring the mechanism and clinical utility of FMT in C. diff infection. Please join me in welcoming Dr. Greenspan.
Sure. Thank you for having me. It was a wonderful trek up from the city. There was trees. It was wonderful.
Are you in the folder or do we?
No, right there. It's perfect. So Dr. Kadish mentioned a great story about his mother, which is an all too familiar story. I'm a gastroenterologist, so this is what I do. Your mother would have been my bread and butter. And the bottom line is that we don't have the best treatments for patients who have those kind of ailments. And perhaps the microbiome might be the answer to some of those questions. Dr. Amar mentioned that we are 10% human and 90% bacteria, except, of course, after a good bowel movement. Then it evens out a little bit. If you are a geneticist, we are 1% human and 99% microbial. So maybe we're the parasite. I'm not exactly sure. So today we'll be talking about the power of poop, how fecal transplant can potentially transform medicine, and it's already transforming medicine. This is our gut microbiome. The gut microbiome is different than the skin microbiome. It's different than the microbiome in the mouth. It's different than the microbiome between your toes or in your whatever organ system you're looking at. What's interesting is about 100 years ago, one of those things would have killed us. We would have died from an organism that caused some sort of infection. That's not the case anymore. We're very good at wiping out any kind of microorganism that could kill us. We don't die from those. We die from heart attacks. We die from stroke. We die from cancers. We die from other things. But we don't die from this. The pendulum has swung. Perhaps it has swung too far. Today, we're going to talk about the importance of the gut microbiome and potentially using this as a therapy. Looking at microorganisms, bacteria, as a way to help us as opposed to hurt us. And that is a major paradigm shift in medicine. This is the first major paradigm shift in quite some time, where we're looking at something that was a source of evil and harm, and now we're using it as a therapy. So our microbes matter. Now, we know about some of the bad microbes, cholera, Shigella, E. coli, Salmonella. Those are probably still mostly bad because they tend to cause disease, but they are by far and away a small minority of the important bacteria, the commensals. And this is a very important thing that we've discovered, that our gut has a trillion or 10 trillion bacteria in it, and they are there for a reason. They help provide the traits that genetics did not give us. They help us to break down plant polysaccharides, to generate vitamins. They help our immune system develop, to recognize what is good and from what is bad. and many different associations with health. This is a very complicated slide. To break it down about how the importance of the microbiome, the gut microbiome, is to our health, there are sort of three categories. Metabolism. The bacteria help deconjugate bile acids. They help degrade fiber into short-chain fatty acids. Then there's the immunity. They help us to develop our innate immune system. They have upregulation and downregulation of certain inflammatory cytokines. And when this goes out of whack, then we can get into some sort of problems. That's what we call inflammatory bowel disease. Then there's a colonization resistance. The bacteria are our bacteria. And what's interesting is the vast majority of the bacteria that we have since the age of 3, those are the ones that we still have today. So while at my bar mitzvah at 13, I became an adult, when I was 3, from a microbiome standpoint, I became an adult. So the microbes that I had my first kindergarten crush, when I went to medical school, when I did my first fecal transplant, those are the same bacteria that are with me today. Except if you go to Peru, things might change for a short period of time. What's good is that that will most likely go back to your normal since you're drinking coffee and you're living in Westchester or wherever you might be living. Your microbiome changes back to your original environment in the vast majority of cases. Okay. The microbiome has been associated with all different sorts of conditions. And what's interesting is that it's really only over the past 10 to 15 years that we have discovered this association. Now, association does not mean causation. So while we're looking at the microbiome and we're searching for answers, we may not find the answers that we're looking for. But we don't know, so we're going to continue to keep looking. The problem is, again, causation or association, I'm sorry, does not mean causation. Okay. What's interesting is that as a gastroenterologist, I focus on inflammatory bowel disease, ulcerative colitis, and Crohn's disease. And what we do know about IBD is that it is associated with dysbiosis. Dysbiosis is the word that we use to characterize when things aren't quite normal. So if you look on the bar on the left, that is what we consider a normal-ish microbiome. It's dominated by Bacteroides and Firmicutes, about 80% or so of the bacteria. If you look at a patient with IBD, that ratio is sort of flipped on its head. The good, healthy bacteria only encompass about 20% of a patient's microbiome, where 80% are dominated by actinobacteria or protobacteria. So there's something that is there. The problem with most of these conditions, and especially with inflammatory bowel disease, it's not just one thing. It's not just the bacteria. There's genetics. There's an altered immune response. There's your environment. IBD didn't exist in Asia until the past couple of decades. It didn't exist. There was no cases of Crohn's disease in the 1900s in Asia. It wasn't until about the past 20 to 30 years that there's been a tremendous influx of the diagnosis of IBD in Asia. Why is that the case when that's something that we've known about since Earl Crohn in the late 20s and early 30s in the United States discovered inflammatory bowel disease? But we've known about it in Eastern Europe for about 150 years or so. Okay. It's something more than just the genetics. It's more than all these things. It's all of them combined that give you IBD. And one very important component is the bacteria or the microbes. And we know this because in every single model of inflammatory bowel disease, if you look in the middle, all of those knockout mice that should trigger a colitis, or in rats, or in guinea pigs, or in primates, if you grow those back, or if you take the whatever model you have, and you have a germ-free model for it, you do not get any immune activation. You do not see colitis. It's only in the presence of the commensal bacteria. When you add bacteria back in, that's when you see all the inflammation come to play. So we know that the bacteria are very, very important. Exactly how and why, we're still trying to figure that out. Now, C. diff. So technically it's now Clostridioides difficile, but we can still call it C. diff, thank goodness. This is a very bad bug. We, as clinicians, we see it all over the place. We see it in the community. We see it in the hospitals. It causes a rip-roaring diarrhea, and it accounts for about 15 to 30,000 deaths per year. Recurrent C. diff happens to be a very significant problem. 20% of patients who have an episode of C. diff, when they're successfully treated, 20% will come, they will get another infection. 40% of people who have 2 episodes will have another one, and then so on and so forth, where over 50% of people who have at least 3 episodes of C. diff will continue to get it over and over again. Why is that the case? We think it's because in the setting of having 1, an antibiotic, and 2, C. diff, the underlying diversity and numbers of bacteria in your gut get reduced. So if this is your normal, healthy gut with all of this lovely bacteria there, most of the time it's there to prevent you from getting C. diff in the first place. It keeps all those bad actors out. In the presence of an antibiotic for a pneumonia or for an ear infection or whatever it may be, while we are prescribing the antibiotic to kill the bad actor, we are crushing, destroying the gut microbiome. And we're losing that colonization resistance. And all of a sudden, C. diff can sneak in and cause a recurrent episode of C. diff. And how do we treat C. diff? Well, we give more antibiotics. We treat the infection, but we're not treating the underlying problem, which is their gut microbiome is devastated. We need to restore the gut microbiome. That's how we think we should be treating C. diff. As a medical student, in college, I loved biochemistry, and I thought this was a wonderful example to bring biochemistry into the world of clinical gastroenterology. So in order to get a chemical reaction, you have to provide activation energy to get from point A to point B. Well, the same holds true for ecosystems. Ecosystems like to be in a stable location, stable place. So to get from point R1 to point R2, you have to activate something. Something has to do that. Okay. Dysbiosis, in terms of the gut, dysbiosis is an unhealthy state of the gut microbial ecosystem. So in terms of C. diff is a treatable, unhealthy, pathogenic, stable ecosystem. So here we are at R1, and that patient gets an antibiotics. And antibiotics can push the patient from R1 to R2. And they get recurrent C. diff. They keep getting this infection. So what do we do when they come to our office with C. diff? Well, we're going to give them more antibiotics, vancomycin, fidaxomicin, whatever it's going to be. The problem is that that is just not enough activation energy to bring them back to state R1. So what do? We repopulate their gut with healthy bacteria. We give them a fecal transplant. We restore them back to from their unhealthy state to their healthy state. And so with gut microbes, we can push them back to R1, and we have about a 90% success rate for the most refractory, most recurrent patient that you can imagine. There's very little thing in medicine that you see a dramatic difference in terms of a delta between the standard of care and for the next line therapy. So in terms of FMT, the standard of care, vancomycin, cures about 30% of the patients who have recurrent C. diff, and a fecal transplant, a single fecal transplant, can cure them 90% of the time. Show me something in modern medicine where there's a delta of 60%, and you get a Nobel Prize. Maybe, I don't know. Anyways, what tools do we have currently to manipulate the microbiome? Well, we have antibiotics, we have probiotics, we have prebiotics, which is basically sugars and carbohydrates and things that you can ingest, fiber that can help sort of replenish and act as fodder for good, healthy bacteria. And then there is this whole idea of fecal microbiota transplantation. Now, FMT is not new. FMT has been around for about 2,000 years. It was first reported in China in 400 AD, and there is text to support its use. Its translation ends up being yellow soup, so I'm always cautious about when I'm ordering at certain restaurants. But they were treating all different sorts of things. They weren't just treating diarrhea and dysentery, they were treating abdominal pain and, my favorite, nausea and vomiting. Okay. It wasn't until 1958 that the first English language publication of using a fecal transplant was used. Professor Eisman in Denver is a surgeon. He did not know what he was looking at. On a rigid sigmoidoscopy on 4 patients with horrific dysentery, he saw this entity of pseudomembranous colitis, which is, you see that picture. We know today that is the hallmark. That is pathognomonic for Clostridioides difficile infection, but we didn't know that they even existed. Now, what's interesting, he read in the veterinary literature that horses who had dysentery, if you fed those horses healthy horse manure, their dysentery improved. So he took the spouses of 4 patients and gave them an enema of their spouse's excrement, and all 4 patients walked out of the hospital. He made a very small splash in 1958, and then it sort of died down into the 80s when we discovered that, oh, this is C. diff, and there was a group in Scandinavia that began to use it. It remained on the fringes of medicine for a long period of time, until about 2013, when it was a landmark article in the New England Journal of Medicine, which showed that 60% difference that I mentioned to you before. Okay. If you are not a gastroenterologist, you may not know that this is a perfectly healthy colon. It's beautiful. You could eat off this colon. You could definitely eat off this colon. That would be fine. Okay. This is C. diff infection of the same colon. It causes a horrific inflammatory response, and it causes horrific diarrhea. This is the explanation for all the symptoms that they have. Have you ever seen a fecal transplant performed? One person, okay. This is a fecal transplant in action. This is a colon with pseudomembranous colitis, and there it is, a fecal transplant being performed. There's no magic here. It is very easy to do. And with this single fecal transplant, this is the patient 1 month later. Remarkably effective, fast, very efficacious. Okay, so the question that I hope is on your mind is, well, where did you get that stuff from? Okay, back in the good old days, we would ask you, the patient, well, who do you trust? Your mother, your brother, your sister, your friend, Joe Schmo off the street, the guy in the office that goes every day at 8 a.m., I don't know. You would tell me who that donor was. I would screen them. I would make sure that they were safe, that they weren't going to hurt you. Screen them for HIV, hepatitis, this and that. And then I'd take it across the street to the micro lab, and they called me Dr. Duty. I would make the dirtiest martini. And I'd shake it up and put it into a slurry that I could then infuse during a colonoscopy. My question always was, well, who are the donors supposed to be? Are they supposed to be somebody like this? Perhaps. Perhaps we're looking for somebody a bit more pious, some holy. Anyways, we don't do that anymore. We have a stool bank. You've heard of blood banks. We have stool banks. There's a bank in Boston called Open Biome, and they do the screening for me now. They actually do the screening for just about every single person in the country. They ship out about 40,000 of these a year now. And what they do is they take healthy college students in Boston, so it's smart shit we're talking about here, and they screen them to make sure that they are safe. But we still don't know what we're looking for in our donors, except for that they are safe. And then they bottle it up and they ship it to me. And so I have a whole bank, I have a whole supply of stuff waiting for a patient if they should need it. This is their screening process. So it's actually tougher to be a donor for Open Biome than it is to get into MIT. Okay. Now, what are we doing by doing a fecal transplant? Well, it turns out, this is a very old slide. This is over 10 years old now. And they took a patient who got a fecal transplant, and they looked at their microbiome before and after. The bar all the way on your left is what they looked like prior to their fecal transplant. This is what we call dysbiosis. The donor is in the middle. That healthy swab of orange is Bacteroides, healthy bacteria. We gave donor, the middle bar, to the person on the left. And the fourth bar, this bar over here, is what the patient looked like 2 weeks after the fecal transplant. You can see dramatic similarities between the donor and the patient. What's interesting is if you follow that patient out to a month, they no longer look like the donor. Now, this patient is doing great, C. diff free, playing tennis, loving life, but no longer looks like the donor. Now, what we do not know is this what the patient looked like prior to their episode of C. diff? We don't have that information. Perhaps this is their new normal, or this is their old, we don't know. All we know is that we have cured them of C. diff. Okay. What are we doing by doing a fecal transplant? We do not know. We have no idea what we're doing. We have some concepts, we have some ideas about what we're doing by giving somebody a healthy swab of bacteria. But honestly, we don't know the mechanism of action. Is it by growth inhibition? Is it by competing for the niches within the colon? Or is it having something to do with the bile acids? So there's phenomenal research coming out that says if you can change the bile acid milieu of the colon, you can prevent C. diff from being a problem. So in our colons, we have secondary bile acids. That is the primary component of a bile acid in our colon. It's supposed to be there. Great. Why is it there? Because a healthy bacteria conjugated the primary bile acids to secondary bile acids, and they have a lot of different functions. If you take a C. diff bacteria and you put it into a milieu of secondary bile acids, the C. diff just stays there. It doesn't do anything. But if you put that same C. diff and you put it into a milieu of primary bile acids, the C. diff explodes. You get all this spore production, you get all this toxin production, and you get C. diff. So maybe by doing a fecal transplant, we are just repopulating with healthy bacteria, which conjugate the bile acids to get to secondary bile acids, which prevents C. diff from causing a problem. Perhaps. Perhaps it's some immune-mediated response, or maybe we're looking at the wrong microbe. Maybe it is not bacterial at all. We didn't talk about viruses or fungi or other things that we are transplanting, and that's really not the right word. We're not transplanting stool, we're transferring stool. There's a kidney transplant. You're taking somebody's kidney and you're putting it to another person. That kidney is the same kidney. It's been transplanted. A fecal transplant it's wrong terminology. It should be a fecal transfer. We're transferring, and then it does its own thing. But we don't talk about the viruses. And not a lot of people are doing that research, and we should, because there's an interesting study out of Germany where they took 5 patients who had recurrent C. diff, and they gave them sterile stool. They took stool, and they filtered out all of the bacteria. Nothing grew. And they gave that to 5 patients with recurrent C. diff, and all 5 patients were cured. My whole concept has completely changed because of this 5-patient study, and which is a good thing. We have to learn more about what we're doing. But I don't talk to patients about bacteria and viruses. It's a little bit too complex. So I bring it down to shades of green as opposed to brown, which my patients like. And I say your gut microbiome is like a healthy lawn, where every blade of grass is a healthy microbe. You could eat off this lawn. Sorry, back to the eating thing. Something occurred where you got an antibiotic and you got these weeds now. Now you have C. diff. Now, as a city boy, I don't have to deal with this problem, but perhaps you do, and hopefully you're not using a particular brand of weed killer, but we use weed killers to kill certain weeds, okay? But the problem is that sometimes those weeds come back. Sometimes the antibiotics don't do the job. And so what we have to do is we have to re-sod your soil. We have to give you healthy microbes to get you back to that healthy lawn. Okay, it works incredibly well for C. diff. Can we then extend this to other diseases? And that is actively being looked at. The problem again is the changes in the microbiome. Is this the cause of all these conditions, or is this just some secondary effect of the disease itself? We don't have the answer, but that's not stopping us from moving forward. This is as of April 2019, there are 287 clinical trials using some version of fecal transplant for a number of different conditions, as you can see on the left. You name it, we're looking at it. We're a little ahead of ourselves because no one can tell you what the mechanism of action of our stool is, but that's not stopping us. We're going to go forward with it. In terms of ulcerative colitis, because I am a practicing gastroenterologist, this is my bread and butter, ulcerative colitis. There have been 4 randomized controlled trials looking at FMT in ulcerative colitis. If you can see on the bottom, these are what the results are, but I'll pull it together for you. 140 patients got an FMT, 137 got placebo. When you look at 8 weeks, 28% of the patients who got a fecal transplant were in remission. What does that mean? They weren't having diarrhea and they weren't bleeding from below and they felt great. These numbers might not seem that impressive, but in the world of ulcerative colitis, 28% remission at 8 weeks is incredible. This is the same thing as all of the biologics that we're using that we tout as this is the primary treatment. So there is something real here. Obesity is a very, very hot topic, and in mice, this seems to work. You can change a mouse's weight based on changing their microbiome. Turns out it's not the same thing with humans. We just had a conference 2 weeks ago where there was 2 trials looking to see if we can change the microbiome via fecal transplant in obese patients. The remarkable thing is that you can increase their satiety. So if you give an obese patient a FMT, they will feel full for the next 12 weeks. The problem is that all of them ate through that sensation. Even though they felt full, they continue to eat. And this is the same thing for all obesity trials. If you don't include some behavioral modification, you're not going to see any significant change. This was my $1 trillion idea, and it works in mice, doesn't exactly work in humans, at least at this point in time. But this is the future, the crapsule. I promise you it will not be brown. The problem is what do I put in there? I don't know, and nobody knows. But there are plenty of companies out there, of new biotech firms that are sprouting up, trying to find an answer because this is a gold mine of opportunity. So the bottom line is that the microbiome, the gut microbiome, it's good. It's important. We need to keep it healthy. It's going to play a role in these new conditions and old conditions that we are aware of. It may not be the answer, though. In terms of C. diff, it's a home run. I mean, I can cure 90% of the C. diff that I see. For these other conditions, it may not be a home run, but it may lead us down to a path to some either new prognostic or diagnostic or therapeutic manipulation. That's just more in the future. Thank you so much for your time.
Thank you, Ari, for this very stimulating presentation. The paper is open for questions. Please. The door's open.
That was great. Could you, I'm interested in the relationship between microbiomes throughout the body, respiratory, skin, gut. Could you make a comment on the effects of FMT on the other microbiomes, respiratory, oral, skin?
That's a great question. So the question was, by manipulating the gut microbiome, do we see changes in other locations? No. The short answer is no. We have not done enough studies to look at this longitudinally, but when we take samples from ears and we take oral samples after a fecal transplant, we do not see changes in a couple of days after the fecal transplant itself. The NIH, with their gut microbiome project, did show there are clear differences in the microbiome in all different locations of the body. But by manipulating one, we are not seeing that you have changes in the other. What's interesting is that atopic dermatitis, sort of a hotbed of research about the microbiome in those patients. Some people are thinking, well, instead of manipulating the gut microbiome, maybe we should be manipulating the skin microbiome. But it's just, we haven't done enough research on that at this point in time.
Hi, that was a great talk. I'm a pediatric gastroenterologist. So I've done some fecal transplants. So I relate to what you're saying. I just had a question on, have you been using FMT in patients who have active inflammatory bowel disease and a coexistent C. diff, which they all do? And it's a huge overlap, and it's very hard to distinguish between the two. So what has your experience been in using fecal transplant in these patients?
So it's a great question, because patients with inflammatory bowel disease are 5 to 8 times more likely than anyone else to have a C. diff infection. And as a clinician, it can be very difficult to distinguish between what's actually causing the symptoms. Is it the IBD or is it the C. diff? So we have a prospective trial that we just finished looking at specifically that question. So active IBD with C. diff, and they failed traditional therapy, we give them a fecal transplant. And we see very similar efficacy rates to those who do not have IBD in terms of the treatment of the C. diff. 80 to 90, actually closer to 90% success rate in this population. We follow to see what happens to their IBD. We see no changes in their IBD. There was some speculation from a couple of case reports that doing a fecal transplant can actually worsen or exacerbate their underlying IBD. We did not see that. And like I showed you before, we're actively looking at this as a primary treatment for ulcerative colitis. So the bottom line is it works, it's safe, and it does not seem to cause any issues with their underlying IBD. We think that the underlying immunosuppression actually plays an important role with how much their microbiome can change long term. So if you escalate somebody's therapy with IBD, we see that their microbiome does not get to that full, rich, robust level. It sort of tapers off at a lower level. This probably has to do with their underlying colitis more than the treatment effect. But in terms of the efficacy of treating C. diff, didn't matter if they were on vedolizumab, if they were on infliximab, if they were on steroids, they all got better, 90% of them. Treating C. diff, not the underlying IBD, correct? Of course.
Thank you. Is FMT a generally accepted treatment now for C. diff?
So if you look at all the guidelines, the ID guidelines, the GI guidelines in America, Europe, Australia, and Asia, it is now part of the guidelines. So if somebody has recurrent C. diff, and that changes by by society, but at least 2 episodes in some areas, or at least 3 episodes in others, FMT is part of the guideline now. So there's not enough data to say whether that's something that you should or should not be doing. There's data from Norway that was published about a year ago today, which showed that a primary treatment of C. diff, this is the patient's first episode, they randomized patients to get FMT or metronidazole. And it looks like there was no significant difference in outcomes between those two. That was a very small study, and most of us aren't even using metronidazole anymore because it's over the past 10 to 15 years, its efficacy rates have diminished. So we need more data for that. But there's a lot of us who would argue that you are on the right track by saying we should be using it earlier and more often.
Yes.
You think that chronic ingestion of glyphosate will impact the
That's a great question. Ingestion of a number of different things is going to affect the microbiome. One of the things that we're actually looking at is emulsifiers. So when we eat your peanut butter and your mayonnaise and your ice cream, it stays in that nice shape. That's not natural. It's not supposed to be that. We add these things, these chemicals, to keep it in those nice shapes. Well, what's interesting is that those emulsifiers come into your gut, into your GI tract. And we have a normal barrier of mucus that separates a lot of the stuff that's in the lumen of the colon from the line, from the cells, that the epithelial cells. When you have mayonnaise or peanut butter or ice cream with a lot of emulsifiers, which the vast majority of those type of foods that we eat, you see a tremendous reduction in that mucus layer, where all of a sudden the bacteria have a much more direct interaction with the colon than it's not supposed to. So there's a lot of things that we ingest that could potentially change things. Specifically what you're asking about, I don't have the answer about that, but we know that there's going to be a lot of effects that we just need to study further down the line. And I don't have a specific answer for you on that, but that's a good question.
I just have a burning question. Is it only a one-time treatment that you have for this population? Any recurrence? The second thing, what do you do for the 50% that you have, that you had 49% of improvement people? What about the rest of the 50% that do not respond to the fecal transplant? Is biologics going to be a combinational therapy, or what do you do for these people?
So the first part is, what do we do for traditionally just a single episode or a recurrent episode of C. diff? This is your run-of-the-mill person who's out of the hospital. A single treatment of fecal transplant, you will get that 90% treatment effect. It's great. And it appears to be long-lasting. It's the sick patient in the hospital, the one who's in an intensive care unit, on pressors, intubated with a rip-roaring C. diff, where a single fecal transplant is not going to cure them. That's where we do multiple fecal transplants over a week or 2 or 3. And then we can not only save their colon, prevent them from getting a colectomy, we can save their life and they walk out of the hospital. So there are certain populations where more is better. For IBD, for inflammatory bowel disease, that's the next thing, to do combination therapy by changing the microbiome, whether it be an antibiotic, a probiotic, a prebiotic, or a fecal transplant, along with a biologic, which is the standard of care currently. We want to do that study. We just don't have the funding to do that study because FMT, as is not there's no company that makes it. It's not a drug. Even though the FDA considers it a drug, you can't prescribe somebody an FMT and have them go to CVS to get that, at least at this point in time. But that's the next step.
Yes.
Is there any diet-based clinical trial or you're thinking of doing that would tell you about which nutrient would be influencing your transplant?
So diet, we've looked a little bit about that. The problem with studying human beings and diet is that they always cheat.
Yeah.
So it's great to do in mice because you can actually control what their food source, but in humans, it never really works. We have done that that's the new thing with inflammatory bowel disease, is that we will be looking at a strict dietary manipulation to see if we can improve those outcomes. But with fecal transplant, we haven't seen anything that actually improves the already amazing result that we have, which is about that 90%. The 10% of people who don't get better, we just give it to them again. And then 90% of those, 10% get better. So there's a couple of patients who would need a couple of doses, if you will, to get to the cure rate. But we haven't seen anything that can change that for the better, or the only thing that changes it for the worse is if they get an antibiotic. Shortly after, that will significantly decrease the efficacy rate.
Thank you, Ari. I'm sorry we have to move with the program. I appreciate very much you being here. You see the number of questions. There's some questions in the storage for you. I'm going to ask a housekeeping favor, I should say. Can we turn off the phones, or at least put them on vibration in deference to the speakers and to the audience? I would very much appreciate that. Our next speaker comes from NYU. Um, he was trained by Martin Blazer. One of the slides that you saw was coming from one of his paper. He's an associate professor in the Department of Pathology. Dr. Pei serves as an attending pathologist in the Department of Veteran Affairs at New York Harvard Health System. He received a PhD from Vanderbilt University, has completed his residency and training in anatomic pathology, has contributed significantly to the space of being under Martin Blazer in the area of the microbiome. His lab defined the esophageal microbiome and has demonstrated its association with the esophageal adenocarcinoma in one of the human microbiome demonstration projects sponsored by the Roadmap Initiative. He's also discovered the link between periodontal pathogen, something that is very dear to me, to the oral cavity squamous cell carcinoma. He's interested in the diagnosis of disease due to what we mentioned earlier, the uncultivable microbial agent in fixed tissue specimen. Please welcome Dr. Pei.
After, wherever you want to put this, you're good to go.
Okay. I used to talk a lot about the microbiome in cancers. We have done, the many projects on the oral cancer, stomach cancer, esophageal cancer, and colon cancer. And today I like to talk about something different. This is a disease is more common than the inflammatory bowel disease and the C. difficile colitis, because as every you know, you have a tonsillitis at some time to your life. If you don't remember, your parents probably remember that. It's nobody can escape this kind of disease in your life. Tonsil not only can cause, develop inflammation, it also can become enlarged. We call it hypertrophy. The hypertrophic tonsil become more and more fashionable recently because it's related to a modern disease that's a sleep disorder or snore, everybody knows. So everyone have one pairs of tonsils in your throat, one on left, one on right. They are gatekeeper for your airways. In a normal tonsil, in the person with a normal size tonsil, the airway is very widely patent. But when the tonsil is enlarged, the airway is very narrowed. When you breathe, the air pass through the narrowed airway, it produces the high-pitched sound, and this may awake other people from sleep. The hypertrophic tonsil caused the sleep disorder affect it had associated with many problems in your life. This is a summary of the the association, how the snoring is associated with the learning problem in schools. In this study, the students were divided into 4 groups based on the frequency of snoring, never, occasional, frequent, and always. In the never snore, about 20 or so percent of students had a problem, learning problem in mathematical science and spelling. But this percentage progressively increased along the increase in the frequency of snoring. in always snorer, about 50% them have a problem in these three subjects. Always snorer is about 3%, 3 times more likely to have a learning problem in school than never smoker, never snorer. The snoring is also associated with the behavior problem. In this study, the students were divided into 3 groups: never snore, ex-snorer, and the current snorer. The current snorer significantly associated with the conduct problem, hyperactivity, inattention, emotional symptom, and the peer problem. And they are about 4 times likely to have a behavior problem than the never snorer. One of the most severe consequences of a sleep disorder is the sudden stop of breath during sleep. This is also called obstructive sleep dyspnea syndrome. This is the obstructive sleep apnea syndrome. This is a very modern disease. It was not recognized until very recently. A person who have obstructive sleep dyspnea syndrome often have excessive daytime sleepiness, fatigue, headache, impaired memory, and poor concentration. They have poor job performance and often cause traffic accident because of excessive sleepiness and inattention. They are also more likely, have higher risk of hypertension, heart failure, dysrhythmia, and stroke. In children, 80% of sleep apnea syndrome cases are caused by hypertrophic tonsils. In adult, its relationship is controversial. But as shown in this study, in the summary of 6 studies, 5 of them show the sleep apnea symptom significantly improved after removal of the tonsil, but one study showed a different story. But anyway, the majority of in majority of adults, removing of the tonsil improve your symptoms. But in very old people, there may be different story. But at least for young adult, this the tonsil hypertrophy contribute significantly to sleep apnea. Removing the tonsil from removing hypertrophic tonsil have been very effective treatment to prevent the complication of hypertrophic tonsils. But there is the adverse effect, and the study has shown that removing tonsil in children is associated with a long-term risk of respiratory, allergic, and infectious diseases. Because it's unclear to know who will get benefit, who will get the bad part of the tonsillectomy, and the public has been taking a watchful waiting approach when it comes to make a decision about the tonsillectomy, as shown by the recent article in New York Times and CNN. Currently, there are very complex scheme to decide who can get tonsillectomy, who don't. This is basically by the number of episodes of tonsillitis you have in 1 year. If you have more than 7 episodes, and you are qualified to get the tonsil removed. If you have less than 7 episodes, it's unclear. So you have to take the polysomnogram and to see if you have obstructive sleep apnea. If the results are positive, you are okay to have the tonsil removed. And in the chronic tonsillitis group, the patient usually don't have acute, inflammation, but their tonsil consistently, persistently enlarged. And for those people, the enlarged tonsil alone is not indicated for tonsillectomy. You have to have a positive polysomnogram results in order to get the tonsil removed. So this scheme is based on the number of the episode, based on number and the size. And because the reason for doing this because they don't know about the cause of the persistent tonsillar hypertrophy, so they get build up those with those arbitrary, the criteria. And for some of those who get a tonsillectomy, it may be better to wait until a few years. The tonsil may undergo physiological evolution, and you don't need to remove it. But this indication may tell you should have the tonsil removed. For those who have a hypertrophic tonsil but have a negative polysomnographic results, they may, should have the tonsil removed because they will suffer the the obstructive symptom, even though not enough to cause sleep apnea. They may have a performance problem in school, in the job, and they are doing bad, in the physical education, like you run for the long distance runner. So this all because we don't know what causes the persistent tonsillar hypertrophy. And tonsillar is the tonsillitis is a very old disease. It's probably one of the first few diseases recognized by humans. In 1896, Dr. Hans Rad and found yellowish granules from the tonsil crypt, as shown by my modern photos. And you can see this is a hypertrophic tonsil. This is the crypt, and in the crypt there are the many large cluster of yellowish granules. And this is what called, because the color, they call it sulfur granule. Sulfur granule at that time already had been known to be a bacteria granule. And they called it, in other part of the body, they called this actinomycosis. But the nature of the identity of the sulfur granule in tonsils are unknown. In 1910, Dr. Law and squeezed the tonsils and collected some content from tonsil crypt, and he smeared the content, and he found the bacteria in there appear to arrange in as an interlacing network or as a colony composed of a dense mass of organisms with radiating peripheral filaments. Then he inoculated the content into the peritoneal cavity in guinea pig. After a few weeks, he sacrificed the guinea pig and found their tumor-like lesion grow in the peritoneal, on the surface of the omentum. And then he recultured and made observed the bacteria under microscope. He said this is bacteria is typical for actinomyces. So his observation had a very big effect, influence on people who work in the field as an ENT doctor or the pathologist. All since his report, almost everyone when reported sulfur granule in from the tonsil, they always call it actinomycosis or actinomycotic granules. However, there was a report show a different opinion. In the 1923, Dr. Davis described the sulfur granule, the bacteria as they are coarse and branched filaments, cochleoform, fusiform organism, and many large spirochetes. These bodies, because their ray-like character, have been mistaken for true actinomyces. He thinks sulfur granule is not actinomycotic granules. It's based on what his direct description, the sulfur granule is composed of many different types of bacteria. Unfortunately, his observation was overlooked by the people who work in the field. Nobody bring up this question to challenge what Dr. Law tell us, the dogma of actinomycosis. So pathologists have been very active in reporting the supragranular actinomyces in tonsils. In the first report, Dr. Raj found 20% of hypertrophic tonsils had the supragranules. And since then, from there until now, more than 3 centuries, and you can see the report had showed the different prevalence of the supragranule in hypertrophic tonsil ranging from 1 to 100%. So we think the supragranule is the cause of hypertrophic tonsils, but it's not easy to prove. In the 1882, Robert Koch developed a famous postulate to illustrate the need, the requirement that to prove a disease is caused by microorganisms. He used anthrax as an example to show that the causative agent must be detectable in the infected host at every stage of the disease. The second, the agent must be isolated from the disease host and grown in pure culture in order to identify the organism. The first two, the postulate basically is to try to establish the association of the agent with the disease. And the third postulate is once susceptible healthy animals are infected with the pathogen from the pure culture, and a specific symptom of the disease must occur. And the fourth, the agent must be re-isolated from the diseased animal and corresponding to the original organism in pure culture. The last two postulate is beyond the association, basically try to establish a specific link between the agent and the disease. Even though this is the most famous approach to prove the cause of a disease with the microorganism, but very few human diseases have been proved to be the cause by this approach, because many diseases have susceptible animal model. And so we decided to try to use the Koch's postulate as a guideline to prove the supragranule is the cause of the tonsillar hypertrophy. We first use a case control study to examine whether the supragranule is more prevalent than in the hypertrophic tonsil than in the normal tonsils. This is the first show the hypertrophic tonsil with supragranule, and and then in the normal tonsil, we see this is a normal tonsil crypt with no supragranule. This is a normal tonsil with the supragranule. So our study included 51 cases of hypertrophic tonsil and 51 of normal tonsil, and from a patient who died of the non-tonsillar disease. And supragranule was found in 88% of cases of hypertrophic tonsils, but only 15% of the normal tonsils. The p-value is essentially 0, and the odds ratio is 40. So it's not an easy task to prove a cause of a disease. So we constantly, seeking guidelines to compare, our finding with successful examples. And Helicobacter pylori was diagnosed in the 1884 by Dr. Warren and Masha, and they found H. pylori was associated with the peptic ulcer disease. So side by side, we compared our findings with Helicobacter pylori in peptic ulcer disease. Our prevalence of sulfur granule of 88% is nearly the same as 87% of H. pylori prevalence in peptic ulcer disease. And however, our association appear to be more specific because sulfur granule here was found only in 16% of normal tonsils, but H. pylori was found in about 50% of in people who don't have peptic ulcer disease. So our odds ratio is 40, and the H. pylori's odds ratio is about 7. So our study finding is similar or more specific compared with the H. pylori. So this is we provide the evidence to meet the requirement of the culture to first postulate to show the agent is specifically associated with the disease. The next, we want to define what's in the sulfur granule. First, we perform the gram stain. This is a sulfur granule, and they show there are probably two area zones. First, in the periphery is formed by the gram-negative bacteria, pinkish, elongated filamentous bacteria, and inside in the center there are mixed gram-positive and gram-negative bacteria. From this photo, we know sulfur granule is not a pure actinomycosis. It at least contains two different types of bacteria, gram-positive and gram-negative. We next isolate the sulfur granule from a tonsil crypt and extract the DNA, perform 16S RNA sequencing, and classify them into the different taxonomic levels. We compare the sulfur granule with the other microbiome in the human body, and this shows the beta diversity analysis with the weighted and unweighted unifrac indices. The sulfur granule microbiome is shown here in brown, is very well separated with the other human microbiome, not only from the distant side, like the vagina, skin, and the colon, but also different from the very close environment, like the saliva and the tonsil surface. At the phylum level, you see the sulfur granule is unique because it contains the high abundant fusobacteria. It's about like a quarter of the bacteria in the sulfur granule are fusobacteria. And in other human microbiome side, the fusobacteria, the level is almost negligible. And in the saliva and the tonsil surface, you see some fusobacteria, but not at the level as you see in the sulfur granule. So the high abundant fusobacteria is the signature of sulfur granule in the human microbiome. And we've then analyzed the data at the genus level. We found in total the 99 genera in the sulfur granule. And the most abundant bacteria there, the genera is the fusobacteria, followed by Prophomonas and the Prevotella. Actinomyces were detected in the 14 or the 15 sulfur granules, but their prevalence, the abundance is much lower, is less than 1%. From these studies, we can tell, this is the sulfur granule is a mixed bacteria. The community is not actinomyces. So then from here, we rename sulfur granule the bacteria metacolony to reflect the mixed nature of this bacterial community. We then sequence the nearly full-length 16S genes and try to identify the bacteria there to the species level. From this limited study, we identified from the 275 clones, we identified 55 species. The most abundant one is Fusobacter nucleatum, and followed by Treponema denticola. And by EM, we found the sulfur granule can be divided by two zones, the peripheral zone and the center zone. And the peripheral zone had like a fusiform elongated bacteria, but the center had much thicker bacteria, and some of that had a thick wall, and that's consistent with the gram-positive bacteria. Using the pure culture of type strains, we found the bacteria with the morphology similar to Fusobacter and to the Treponema in the peripheral zone, and the one similar to the Bacteroides and the Actinomyces in the center. We next localized the bacteria by fluorescence in situ hybridization, and we found the Fusobacter form the outermost shell of the bacterial colony, and this is to show the high power of the Fusobacter at the surface. And the Actinomyces, if you found it, is located between the shell and the center. And the high power view will show the branched bacteria are consistent with the Fusobacter. And the Streptococcus infiltrated the shell here. And at high power, you see the coccoid bacteria in the shell focally. So from what we found, even though culture possibly required the pure bacterial culture to be that we found that we are dealing with probably the causative agent that contain mixed bacterial population. But anyway, I think culture's the reason to ask a pure culture is to identify what you are dealing with. So we are able to identify what's inside the sulfur granule. We are able to reproduce our findings with the multiple different sulfur granules. So I think this in some odd way is satisfied the requirement by Koch's second postulate. The next, we don't have the animal models to test this. So we try to see, are we able to use the human study to provide a specific link of the sulfur granule to the hypertrophic tonsil. The first we've asked is whether the sulfur granule causes acute inflammation. Acute inflammation is marked as here because the acute inflammation is always pathologic. And the acute inflammation has been used by the study of the Helicobacter pylori to demonstrate the Helicobacter pylori is the cause of chronic active gastritis. So it's here, it shows that the sulfur granule here, and on the surface as inflammatory exudate, and it contains mostly the neutrophils and some macrophages. And those inflammatory cells are attacking or trimming the surface of the sulfur granule. And some their cytoplasm contains the fragments of the bacteria. So in the EM, you can see this is a polymorph nuclear cells. They contain the fragments of all intact bacteria, called fusiform, and gram-positive bacteria. And another form of the acute inflammation is in the epithelium near sulfur granule. And this shows this the host epithelium are infiltrated by numerous polymorph nuclear cells. So then we examined the 111 sulfur granules. We found the acute inflammation on the tonsil surface in 99% of the sulfur granules. And we also found acute inflammation in the adjacent epithelium in 76% of the sulfur granules. In comparison, H. pylori associated acute inflammation is found only the 67%. So our finding of the acute inflammation is in the similar degree as H. pylori, or even better. So another way to, this is a tell, the host see the sulfur granule as a pathogenic, even though this is beyond the simple association. The next step we ask, whether we can more process, more specific to establish the link. And this hypertrophic tonsil is caused by massive increase in lymphocytes. And many of those are from the germinal centers, as here. Germinal center is a place where B cell, active B cell, undergoes clonal expansion, and they multiply there and then become antibody producing B cells. So we think our hypothesis is the metal colony release the antigens to active the B cells, and the B cell then migrate to the germinal center to undergo clonal expansion and cause massive enlargement of tonsil. So in order to prove there is such association, we need to establish the antigen antibody relationship between the sulfur granule and the B cell in germinal center. So we isolated the lymphocytes from the hypertrophic tonsils, immortalize them with the EB virus, and we select past the B cells, and at each passage we select the clusters and transfer the cluster into the new culture media, and wait until disperse the granules and wait until the new granule form and pick up the granule and then transfer to the next. So at the first two passage, you see the lymphocytes form the the small clusters, and by the immunoglobulin heavy chain gene arrangement, you find them they are polyclonal because there are multiple rearranged bands. But at about passage 4 or 5, you see the dominant the B cell granules formed. When at this time you do the AGH rearrangement, you found that there are single AGH genes, all the biallelic gene rearrangement. And so this is the cloned B cell. And these B cells are express CD20 and CD38. These are typical for the germinal center B cell phenotype. Most of the cloned B cell produce AGM. In total, we cloned 412 B cell lines from hypertrophic tonsils, and they produce, because they produce antibody in the supernatant, we can use the supernatant antibody to see whether they are against the bacteria in the sulfur granule in the ELISA. We include 9 bacteria from sulfur granule in the ELISA. We found about 1/3 of the 412 B cell lines produce antibody to one of those bacteria. The most dominant one is the Fusobacter, followed by Prophomonas, Tenarella, Helicobacter, and so on. This pattern, is similar to what we found in the sulfur granule by bacterial abundance. In contrast, none of the B cell clones produce antibody to Bacteroides vulgatus, which is the bacteria you found in the colon. So in summary, to establish the association of the agent with the disease, we found sulfur granule or bacterial metacolony is significantly associated with the hypertrophic tonsil with the odds ratio of 40. And the bacterial metacolony is dominated by fusobacteria. It's not actinomycosis. To establish a specific link between the agent and the disease, we found the metacolony is associated with the acute inflammation is seen by the host as the harmful agent. And the cloned B cell recognize the bacteria in the metacolony. And our data is support this hypothesis. The metacolonies may release the bacteria and they captured by macrophage or the polymorphonuclear cell. The processed antigen epitope may be presented to the B cells, antigen-specific B cell, and the B cell may migrate to the germinal centers and to undergo proliferation and cause massive enlargement of the tonsils. And overall, this is if we needed to prove whether the metacolony is when it's introduced in the normal tonsil, it causes the hypertrophic tonsil in the conventional study, either in human or in the animal model. And we think if our hypothesis is proven true, the current scheme for the selecting the people to undergo tonsillectomy can be much simplified. The tonsillitis can be maybe just classified as a metacolony negative one, and then our advice will be the watchful waiting to wait for the physiological evolution. This will reduce the risk for future respiratory disease, allergy, and infectious disease. And if the tonsillitis is positive for the metacolony, and we recommend to take the tonsillectomy, this will reduce the risk for persistent tonsillar hypertrophy and obstructive sleep apnea syndrome. So our work was done by a team of student, resident, microbiologists, immunologists, pathologists, clinicians, and dentists, EM technicians, and bioinformaticians. This work is supported by the National Institution of Allergy and Infectious Disease.
Thank you, Dr. P. The paper is open for discussion. Are there any questions? Yes, please.
How many passage can you do for your B cells that you've isolated? Because I'm just trying to draw the parallel between Helicobacter and this is in the sense that if you continue to passage your B cells, will they actually become autonomous in their growth? And at that point, do you actually see any chromosomal changes?
Yeah, in H. pylori, the story is long-term inflammation caused by H. pylori may non-specific stimulate the B cell, and B cell become autonomous, and you have martoma. That's a very specific example of, but in the tonsil, we don't see such, the lymphoma developed from the hypertrophic tonsil.
Well, the reason I'm asking is that I remember there was a study that was done looking at fish analysis of tonsils taken out from kids, and that a big proportion of the tonsils actually exhibited that 14-18 translocation. And yeah. And so I'm just trying to draw the parallel to martoma that eventually when they become autonomous, due to Helicobacter stimulation, some of them actually start acquiring 11-18 translocation?
Yeah, we asked this kind of question. We did the BCR2 staining to see whether germ center is express BCR2. This against apoptosis, but it's not. It's not like the lymphoma like a feature, but the genetic component is, I think, is highly likely. There are studies to show the hypertrophic tonsil run in family, and I don't know that's be at the high, immunoglobulin gene different and or may other, but they do have a genetic component there. But this genetic component may be different from what you think is the hypertrophic tonsil cause genetic change. Probably this kind of somatic genetic, susceptibility.
Any other question, please?
Was there uniformity between all of the sulfur granules, or was there a diverse population?
There is qualitatively all the sulfur granule examined show the similar feature. Quantitatively, they have things different. Let's see, you can the highest one had like near 40% of fusobacterium, but the lowest one may have only like 15%. But this is even though the lowest one, still is you never found this much fusobacteria in other body of it. So they are not similar to each other, but there are variations.
General microbiome of the oral and pharyngeal cavities. Have there been any studies looking at that in the relationship oral carcinoma?
Oropharyngeal carcinoma is more likely to be caused by the human papilloma virus.
Also, does oral microbiome affect the activation of the patients that would cause HPV? Is there a relationship between microbiome and HPV positive?
Yeah, people are studying that. I think in the gut, it's the bacteria virus interaction is a hot topic, but it's just studied in the oral cavity. We did one study, the microbiome and the HPV in oral cavity cancer. But oral cavity cancer is a little bit different story because there are probably only 5% of oral cavity squamous cell carcinoma are caused by the HPV. This is about 70% of oropharyngeal carcinoma caused by HPV. So it's a little bit different. And we found, in the oral cavity, it's barely you can detect any HPV, but you do see the periodontal pathogens are highly associated with the disease progression, from normal to pregnant, leukoplegia to oral cancer. So we tried to find the virus bacterial interaction, but the virus was not there. But for oropharyngeal carcinoma, you may see that. We haven't analyzed the data yet. We have those data produced.
Some of the oral microorganisms have now been found as pathognomonic and involved in pancreatic cancer. F. nucleatum that he finds in the sulfur granules, essentially in P. gingivalis, have been involved in the pancreatic cancer. We have a paper on that, as well as some of the gastroduodenal cancers. So somehow the whole digestive system is going to be involved. You probably have some kind of contamination in the mouth, and the swallowing of those microorganisms is probably going to be involved. It's interesting. Any other question? Thank you so much, Dr. Pei. Our next speaker is Dr. Adams. He's a professor and director of the Microbial Genomics Service at Jackson Lab for Genomic Medicine. He develops and applies over there approaches for microbial profiling in human studies and develop mouse model for demonstrating the role of microorganism in disease. Comes from a rich background, industry, government, academic, nonprofit. Is the leading edge of genomic and bioinformatic approaches. He has contributed extensively on the first genome sequence of a free living organism, Haemophilus influenza, as well as the microbial genomes, a co-founder of Celera Genomics. He led the DNA sequencing and genome annotation groups, and he directed the Drosophila human and mouse genome sequencing project and a large scale of resequencing. Please welcome Dr. Mark Adams.
Well, thanks for the opportunity to present a little bit about what we're doing. The Jackson Laboratory, as you may know, was founded just 90 years ago. We just celebrated our 90th anniversary last month. And over time has grown to be the largest provider of research mice in the world, and currently offers, amazingly enough, over 10,000 different genotypes of animals. I didn't know that there were even that many available, but there are still many programs involved in continuing to create new mouse models, as with part of the NIH Knockout Mouse Consortium, for example, a project that we're now trying to look at whether some of those mutants affect the microbiome. Unfortunately, I can't tell you about that yet today because the data just came off the sequencer, but stay tuned for some of those things. In 2014, the JAX was looking for an opportunity to expand into translational projects and human genomic medicine and selected a site in Farmington, Connecticut for that expansion. And the building has been open now for a couple of years. As part of that, the microbiome was identified as an important area for the initial faculty recruitment for this new JAX Institute. Among the early faculty members were George Weinstock and Julia O, who have quite extensive backgrounds in microbiome science. George was one of the founders of the Human Microbiome Project, and really tight interactions with other investigators in the areas of particularly cancer and immunology, although Alyssa Chancellor in Bar Harbor works on addiction. And George and one of her staff scientists have a large grant to study the impact of the microbiome in a variety of addictive phenotypes. What got me interested in the microbiome was early studies that were addressing this issue that we've talked about already this morning, which is the demonstrating causality as opposed to simply causation for roles of the microbiome in any given particular phenotype. And this is a series of papers that were published in Science at the beginning of last year, 3 studies showing that stool from human patients who responded to immuno-oncology agents, checkpoint inhibitors, could be transferred to mice, and the responsiveness of the patient transferred to the mouse model of tumor development with the microbiome. So this is one of the strongest examples that I've seen where the mouse has been a useful resource for demonstrating causality in a human context for the microbiome. Now, there are, of course, limitations in using mouse as a model, but frankly, there are limitations in using humans as a model too. And so I think some combination of these two things is really going to be quite important. As you've also heard this morning, variation in the mouse microbiome is a confounder in a number of studies. The checkpoint inhibitor studies, where the role of the microbiome was initially discovered by accident as researchers were unable to replicate findings between Charles River and Jackson Laboratory mice, and then therefore suspected that the microbiome was a contributor. Whether the microbiome is contributing to irreproducibility of studies between centers in a broader area, I think is a question that's really an open one. One of the things that we really struggle with in designing microbiome-based experiments is whether to try to engineer or design out all of the variability, which of course is very difficult, but very tempting from a scientific perspective, so that we can be sure that we're studying a simple, pure experimental question, or whether to retain some of that variability, experimental variability, so that we have more confidence that any answer we get is applicable across a broader range of model systems, investigators, and so on. I don't have an answer to that question, but I think it's a fair one to ask as part of any experimental design. Craig Franklin has been doing a lot of work at the University of Missouri in looking at the microbiomes of mice from different vendors and what happens to them as they adapt in a new facility once those animals are received. Jax has been doing a number of studies along those areas as well. Again, I'm not going to talk not really going to talk about that today. Rather, I'm going to talk more about some of the challenges that remain in using mouse as a model system more from the genomics perspective. So several years ago now, the NIH Human Genome Project or Human Microbiome Project published a series of papers in Nature and other journals, the result of a several $100 million investment in creating the resources that have really facilitated doing research on the microbiome in human systems. This is one of the figures from one of those papers showing a phylogenetic tree with the really incredible diversity of organisms that are present in the microbiome at quite varying relative abundance across different sites. And of course, this was all in healthy individuals. Well, in its infinite wisdom, the NIH did not decide to make a similar investment in the experimental systems that are used to understand a lot of human traits, including the mouse. And so when we do mouse microbiome experiments, whether that's 16S profiling or metagenomic sequencing, a very large fraction of the sequence reads can't be mapped to known genomes in GenBank or any other reference. So for the 16S side, which is on the left here, we see that 75% of the OTUs, or operational taxonomic units, are classified as either unclassified Lactospiraceae or unclassified Ruminococcaceae, not particularly informative names. And that's 3/4 of the information content of the data. So we're forced then to do analysis essentially at almost anonymous OTU levels, which is statistically fine, but not particularly biologically meaningful. Likewise, when we do metagenome shotgun sequencing, somewhere between 10 and 25% of the reads map to a known sequence in GenBank. And we can squeeze a little bit more out of that by doing translated searches against proteins. But the fact remains that the resources, the references for mouse metagenome profiling are really still limited. And so I'm going to tell you a story about some of the things that we've been doing to try to enhance that and increase the toolkit that's available for working with mice. And as part of doing that, we'll be using one experimental system. I should say, as this is really an aside, that there's quite a bit of interest now in using full-length 16S sequencing as opposed to just the V4 or V1, V3 region, and improvements in the PacBio technology for getting accurate long reads has really helped that, provides a lot more phylogenetic resolution. The limitation still being if you don't have the references, then that's a problem. So in metagenomic analysis, a lot of people are moving away from 16S toward metagenomic sequencing because of the higher information content and the higher potential for getting functional information from a study. There are a variety of levels of analysis, of approaches for doing that each have a variety of strengths and weaknesses. So at the top here is essentially a 16S or other kind of marker gene analysis, where you can get a very comprehensive and profile of whatever's in the community. If you're looking at a very narrow slice of the genetic material, you can really go to very deep analysis and have a good sense that you're seeing all of the organisms that are present there. On the other hand, by looking at the whole genome shotgun, you have access to all of the genes and therefore more information about their function. And there are two basic approaches for dealing with that kind of shotgun data. One is blasting against gene sorts of databases and trying to get a gene catalog. And the other is an assembly approach. As you might have heard, I was at Celera Genomics, involved in several genome projects over my career. I happen to be a big fan of genome sequencing, that the organisms that we're trying to study are more than just collections of genes, that it is really helpful and important to understand how those genes are organized into genomes, and it is at the level of the organism that we see function play out in these systems. So all of the binning-based methods or read-based methods, while they don't rely on assembly, do rely on reference databases, matches to known genomes, matches to proteins that have annotations, and so on. Whereas the assembly approach, of course, is limited by the fact that you have to assemble all of the reads. And that is a major challenge. It's a major challenge even for pure genomes that don't vary in copy number. There's a several log difference in organismal abundance for microbes, and that is a real challenge for microbiome assembly. But if we can do that, we can get genome sequences and understand how the genes are organized into genomes. So that's the approach that we're trying to really push, is understand what we can get out of doing this with the technologies that are available to us today. The project that I'm going to use to describe, that we use to collect the data to explore this question, is a single mutant E and U induced mutant mouse line that's called HLB444 that is resistant to weight gain on a high-fat diet. So the mutation is in a zinc finger transcription factor gene. It's expressed in a variety of metabolism-relevant tissues. There's not necessarily a clear answer as to why it doesn't get fat on a high-fat diet, but we were curious as to whether there might be a role for the microbiome and whether the microbiome was different in these animals. On the left, you can see in the yellow, these are the HLB444 animals on a high-fat diet. They don't gain very much weight, whereas black 6 littermate controls do gain quite a bit of weight over the course of this study. So we took black 6 animals and HLB444 animals on a chow diet and switched them to high-fat diet. They were assayed then for a couple of days immediately after that switch and then 5 weeks later. And we were interested in both, is the baseline microbiome different between these two strains? So does the genotype predispose to a different microbiome? And is there a different response to high-fat diet that is associated with differences in their pattern of weight gain? And in order to do that, we collected 16S data, metagenome data, and metatranscriptome data. Several billion reads, a couple of billion reads in each case. And of course, the nice thing about having a lot of data is you have a lot of data and a lot of opportunity to explore that in a variety of ways. And the disadvantage of having a lot of data is that you have to figure out what to do with all of it. So I'm going to tell you a little bit about what we've tried to do. There are lots of different levels at which that analysis can be done. The 16S level, of course, we make OTUs. We can do a variety of different ordination plots and transformations to try to understand how samples cluster with each other, which ones are most similar, and what's driving those differences. We did a metagenome assembly that I'll talk about in a little bit of detail. Those assemblies can also be used to organize the data by mapping all of the sequence reads back to the assembly and getting abundance information for every contig that can also be looked at using the ordination methods. We can also map reads or predicted genes from the contigs onto proteins and KEGG orthologs and then look at higher levels of analysis. So looking at the most simple level, by way of introduction, these are plots of the phylum level OTU abundance for several different phyla of bacteria. The time points here are 0 is the chow animal, and you'll see that on several slides. T0 is animals that were fed chow. Time points 1, 2, and 3 are days after the shift to high-fat diet, and TT is 5 weeks later. So in each of these phyla, there are differences both at baseline, before the animals were put on the diet, and in their response to diet after they were shifted. And that happened immediately, starting on day 1. You can see significant changes in the microbiome right away. And those largely, it's not the same as 5 weeks later, but it looks more like the final time point than the original time point. So the changes are rapid and largely durable. The disadvantage of this plot is in the little key down here, which is that most of our OTUs are hidden in this one Firmicutes plot. 295 of the 300 and some OTUs are mashed together in this. So we're losing a tremendous detail about what's really happening. When we zoom into the OTU level, we can see a variety of differences among responsive microbes to the diet. The shared responses are here. For example, these are up in high-fat diet or down in high-fat diet in both genotypes. But we see a lot of organisms, or OTUs, that are increased or decreased only in one genotype, for example, black 6 or HLB444. And if we look at the Venn diagram of all of those possibilities with the mutant on the right, black 6 on the left, diet on the top, high-fat diet on the top, chow on the bottom, we can see that most of the differences are genotype specific. So rather than having a shared response to the high-fat diet, the microbiomes differ in their alteration in response to high-fat diet. And so we do feel like that is a potential contributor, although it's still at the association stage, to the metabolic differences that protects them from weight gain on the high-fat diet. So then we decided with the metagenome data, well, let's start with assembly and see what we can do with that. And the process of assembly is that you begin with the raw reads off the Illumina sequencer, clean them up, get rid of vector inserts, adapters, et cetera. And then we assembled with MegaHit And then we grouped the contigs that result from that assembly into bins. These are called clusters, bins, metagenome assembled genomes, which seems a little like a repetitive redundancy, but that's the term of art in the community, or MAGs. And so those bins are groups of contigs that are advertised to represent a single organism. And you can check that with CheckM that looks for the presence and copy number of single copy prokaryotic genes. So if you expect 100, so it's a database of 100 or so single copy genes, if you get one and only one in a set of contigs for each of those, you can say with some confidence that it represents a single organism. Whereas if you have double copies of a lot of genes, it's contaminated. If you're missing a lot of those universal single copy genes, it's incomplete. And so this isn't a perfect representation of a genome, but it's a very good QC metric that we use. When we look now at the PCOA plots at the 16S level and the metagenome level, they really look very, very similar. So what we have here is the metagenome data is at the top and the 16S data is at the bottom. The two, on the left-hand side, the two genotypes are colored differently. Black 6 in blue and HLB444 in red. If you're not familiar with these plots, this is basically a two-dimensional representation of how similar all the samples are to each other. Each dot represents a sample, and two dots that are close together share a very similar microbial profile. Dots that are further away have a more different microbial profile. So the fact that a lot of the black 6 animals fall into two little clusters means that they're really quite similar to each other. On the right, they're colored by time. And the red points here are at T0, or animals that were on the chow diet. And so you can see one of those clusters for each genotype. Okay? So the animals, there's a fair amount of consistency, and they change in a predictable way once they're put on a high-fat diet, and those patterns are very similar whether we're looking at OTUs, read counts per OTU, or reads mapped to the contigs from the assembly. So the assembly was okay, but I always want to do better. And so we've looked at now two things to improve the assembly quality. I'm going to tell you about one of them. The other, I'm still trying to figure out how to deal with it. So the one I can't tell you about is PacBio. I think it will help in assembly to have long reads, but the software really for doing that analysis is still a work in progress. So if anybody's interested in talking about that at the break, I love talking about assembly. I'd be happy to talk to you about that. But for right now, I'm going to talk about a different method for improving assembly using an experimental technique called Hi-C. Some of you may have heard about this as a mechanism of looking for pieces of DNA in the human nucleus or mammalian nucleus that are adjacent to one another by chemical cross-linking. So physical piece DNA that is physically adjacent to each other can be cross-linked, and then those cross-linked fragments can be pulled out and made into sequence libraries. And you can reconstruct which of those were near each other. In the context of bacteria, if we do the chemical cross-linking in bacterial cells before we do the DNA extraction, we can say that any cross-link that occurs must have happened within a cell. And so those two pieces of DNA must have come from the same chromosome. And to do this, we used a kit. Did I go backwards? Let's see, I went forwards. So that's described here on the left, the Hi-C process. And we used a kit from Phase Genomics. There are kits available from other vendors. Dovetail is one example. I don't mean to, I am not attempting to promote Phase as opposed to any other vendor for this approach, more that it was convenient to run for us. So what was the impact of the assembly when we incorporated this new long-range linking data? There's a bunch of numbers here, but I'll just walk through a couple of them. First of all, we had about half of our contig length could be assigned to one of these bins or genomes, metagenome assembled genomes, in the initial assembly. And that went up to 75%. And we had about half of the reads mapping to those organisms, those genomes, in the original assembly. And that went up to almost 90%. So now our binned assembly data in about 770 pieces, instead of billions of reads, we're now talking about 770 functional units, many of which represent individual genomes that we can use as the basis for analysis. It's a much more concise and organized framework around which to do the rest of what we were interested in doing. So this is a plot of the completeness on the first y-axis versus contamination or overrepresentation of the marker genes that I mentioned on the secondary axis. And these are just sorted in order of completeness. So you see in this data set, we had about 50 pretty high completeness genomes, and then quite a few that were of lower completeness, and so don't represent entire genomes. Remarkably, of these, only 8 match sequences that have been deposited in GenBank as genomes. So there's a lot of information here that we can gain by annotating these genomes and using them as the basis for analysis. I'm now going to show different ways of looking at the data that were derived from 2 other assemblies of different data sets. So we've now applied this method overall to 3 different data sets. So this one is a set of diversity outbred mice that were fed 2 different diets. And there was about 3 times as much raw data. So a much larger experiment contributed the number of sequences for this data set. And what we're looking at here is the length, which you could think of as genome length, or the assembled metagenome assembled genome length, and the completeness on the y-axis. So there are a lot of high completeness bins representing likely individual genomes. There are a few that might be twice the size of what you think of as what a genome should really be in length, or they could just be very large genomes. And then there's sort of a tail down here where we're seeing less complete genomes that are, of course, shorter, which kind of makes sense. We're also interested in how does the assembly quality relate to the abundance of the organism that was present. It's entirely reasonable to think that high abundance bacteria will have more reads, and that more reads will result in a better assembly. Whereas if there's just a tiny trace of an organism present in the sample, it won't generate enough sequence data to result in a good assembly. And that's kind of true, but it's not really the whole story. So we see very good assemblies of organisms that are present at really pretty low abundance in the sample. One of the things that we've really learned by looking at all 3 of these data sets is that certainly sequencing deeper and collecting more data would help with assembly, particularly in these low abundance organisms. We also see a fair number of reasonably high abundance organisms that don't have very good assemblies. They're not highly complete. And this, I believe, is a reflection of strain level diversity that makes assembly challenging, where you have a variety of different presence or absence components or variable gene content, alternative alleles, insertion sequence, and other things that break the assembly and make it harder to put together as either contigs or as bins. When we combine all 3 of these assemblies from our HLB data set, the diversity outbred, and the last one that I showed you was a pretty deep sampling of only 3 strains of mice, which are founders for the collaborative cross mice. We have a union of this set of about 430 metagenome assembled genomes that are now going to sort of form the down payment or the deposit on a mouse reference genome assembly. George Weinstock's group and Julia O's group are both doing some culture omics projects in which they're trying to systematically culture organisms out of mouse stool and human stool in the case of Julia. And we're, over time, will be attempting to match these computationally instantiated genomes with an actual organism in a culture with a complete genome of an isolate to flesh out that relationship. Okay, let me come back to the HLB study and talk a little bit about how we've used some of this information going forward. So just to remind you, we have these 2 different genotypes of animals, wild type and the mutant that's resistant to high fat, to weight gain. And we have data, which I haven't showed you the transcriptome data yet, about DNA abundance, and from the RNA-seq data about gene expression abundance. And so there are a variety of confounders in this study, one of which is that if you just count transcripts, of course, the genomes that are more abundant, the organisms that are more abundant, will have more transcripts simply because they are organisms that are more abundant. So they're not independent of one another. I'll come back and talk about that in a minute. So I'm going to walk through just a couple of mappings of functional groups of proteins to these data and show some of the a snapshot of the findings, but also some of the strengths and limitations. So first of all, this is a single KEG ortholog. This is a functionally annotated protein in the KEG database, and we can assign all of our open reading frames from all of the genomes that we find to that KEG annotation, and then count the reads that are associated with that in both the DNA and the RNA level. So in this case, the DNA is in blue and the RNA is in red. And at the time 0 time points, there's quite a bit of signal at the DNA level. That means organisms that contain this fructose degrading enzyme are present. But the RNA-seq reads are low in all cases. So that means that it's not expressed under any of the conditions, either of the genotypes or either of the diets. Excuse me. So we might be misled if we had only the metagenome data to look at into thinking that this fructose metabolism was an important distinction between the diets in both of the genotypes. And it's probably not the case because the gene isn't expressed. Okay, here we're looking at the DNA on the x-axis, DNA abundance, and RNA abundance on the y-axis. In this case, the colors blue is the mutant and red is black 6. So this is now a group of KEG orthologs involved in glycolysis. This is a KEG module. And what we can see here is that there is a little bit of difference, maybe, between the blues and the reds. So there's some genotype-specific difference, but in each of these cases, to a first approximation, they're nice little tight clusters. The DNA and the RNA aren't really telling us much different about what's going on, although there might be a little difference between the two strains in terms of their relative abundance. Okay. And one more level, this is looking at lactose transport system. And in this case, we see quite a bit of variation in the RNA-seq abundance because we have a big scatter on the y-axis compared to the DNA level abundance, which is relatively consistent. The two genotypes are pretty well interspersed, and I recognize it's difficult to see on this plot, but there tends to be lower expression on the high-fat diet time points. So this is something where the RNA-seq data is suggesting that there's a regulated response on the high-fat diet that results in reduced lactose uptake. So this is what we're trying to do to integrate these two data sets to look both at the transcriptome and at the DNA level. I will say that we tried to do this at the organism level, the way you would if you had an E. coli and you grew some in one condition and some in another condition and you did RNA-seq, and you tried to simply do differential expression analysis on every gene in single genomes. And we determined that we have nowhere near enough transcriptome data in order to do that, even for relatively abundant genomes. By the time we have billions of reads, but by the time you recognize that there are several hundred organisms present in the sample and that they have several logs of difference in abundance, there just aren't enough reads per gene, per organism to really get the kind of power to do differential gene expression analysis on a genome by genome basis. So when we bundle it all up together, if we look at the ORF level, and this is again complicated, but I have some cheat sheets here. We're looking at the differentially abundant ORFs at the DNA level on the left and at the RNA-seq level on the right. And these Venn diagrams show shared patterns of differential abundance based on the genotype, black 6 versus HLB, and based on the diet, chow versus high fat. And so the important take-homes from this, without walking you through every single number, is that as I showed for the OTU plots, there's more strain-specific response to diet than there is shared response. There are, interestingly, many genes that are lower at baseline on chow in the mutant animals and that are reduced on the black 6 animals on high-fat diet. So in some ways, the black 6 are becoming more like, their microbiome is becoming more like the mutant animals in response to high-fat diet, which I think is very interesting. And secondly, or finally, there are the patterns, if you look at where the numbers are on this plot. The RNA-seq data really looks very much like the DNA data. And that really as a result of the organismal abundance having more signal than the RNA-seq data on its own. And so we feel like we really didn't get what we wanted out of the RNA-seq data. I'm looking forward to the presentation later this morning on the transcriptome analysis in human samples to hear about tips and tricks that might enhance our own work here. And then we can go further up the food chain, the annotation food chain, to look at differentially abundant modules and pathways in KEGG, and the overall pattern of the distribution of genes and what's up and what's down is pretty similar. So we see the same overrepresentation group that's shared between the black 6 and the high-fat diet and HLB at time 0. Though, of course, this has everything that I've shown has been association. And so one of the things we're looking at going forward is co-housing at fecal transfer and other things to see whether or not we can more definitively link the mouse microbiome to a causal effect in this genotype of mice. So to summarize, I think it is possible to construct mostly complete genomes from metagenomic data, and this long-range linking information really will be helpful both to construct those metagenome assembled genomes and to validate those computational sets of binning. The genome sequences themselves are really quite useful in terms of improving taxonomic resolution, which I didn't show, as well as functional content. And I'm intrigued by the metatranscriptome idea, but I think we probably need more data and more analytical tools. Some of the things that we're really interested in doing more with going forward are the diversity outbred mice. These are groups of animals that share the extent of variation across a relatively small group of animals that is equivalent to that in a human population, but where you can do genetic mapping with about 150 animals to get information about what genes are associated with any given particular phenotype. Very powerful way of accessing a great deal of genetic variation with a small number of mice derived from 8 different founders. We still need work on the statistical analysis. Unlike everything else, and you guys, I don't really preaching the choir here, unlike everything else in next-gen sequencing, statistics rules the microbiome. And yeah, there's statistics and gene expression analysis and stuff like that, but the tools and methods and approaches and validations and controls are still really much a work in progress in the metagenome area. And with that, I'd like to just finish by thanking folks in my group that have helped out with this, Asaf Pear, who did a lot of the assembly, George and Julia, who provided a lot of the samples and great conversations as well. And thank you for your attention.
Thank you, Dr. Adams. The paper is open for discussion. Any question? And I'll take the prerogative of a chair to ask the first question. You mentioned the resistance on the high-fat diet to obesity in that strain. First question, any high-fat diet would give you a resistance, or the 60% fat with the some of the carbohydrate that we have the standard?
Yes. So this is a very important clarification that I should have made at the beginning. It is a high-fat, high-sugar diet. It is not only high-fat. So that's one thing. Other diets have not yet been tested.
Yes. There was one point in your high-fat diet study that I did not catch. Could you do longitudinal sample collection with metatranscriptome analysis?
We did.
Okay. And what was your observation?
The changes looked very much like what we saw at the DNA level. So we really didn't see anything that was unique to the transcriptome. And as I said, it's possible that that was a result of undersampling. We had about 10 million reads per sample, which is apparently not enough. Yeah.
Did you do transcriptomic analysis of 44 and 67?
So we have done, so the question is, was there transcriptome analysis of the mouse strains? And Karen Svensson, who identified this mouse, she has done gene expression in the liver, and there are substantial changes in the gene expression patterns in the liver associated with a variety of different metabolic pathways, and interestingly enough, circadian rhythms are disrupted in this animal. I should say, clock genes are disrupted in this animal. I don't know about the rhythms per se.
Hi, I have a question about the data analysis tools that you're using. How would you choose one analytical tool over another? And how would you know that which one is real
Which one is
deal.
right? Yeah.
Yeah.
So everything we do, particularly with the 16S analysis, we look at several different ordination methods, distance metrics, plots. We look at both rarefying and non-rarefying, log transform, no log transform, Bray, Jacquard, distances, a variety of other things. And we look for a consistency in results that spans those different analytical approaches. So you can try a bunch until you get the one you like. That's not a good way to do it, generally speaking. So we look for patterns that are robust to how we ask the question, basically. Yes. So if we're trying to see if two groups of samples are different, do we only see that with one clustering method, or do we see it across a variety of clustering methods? And some of those have information content about whether it's abundant organisms that are driving the change or rare organisms that are driving the change that we can then flesh out further using Permanova or other kinds of methods.
Any other question? Hearing none, we're going to take a small break. If there's some fruits, please help yourself in the back, and we'll reconvene in 10 minutes for the next session of the program. Thank you. Thank you, thank you very much. We're going to get back on track. If everybody can take a seat for the second session. Shh. Thank you. The next speaker is a dear friend, a collaborator. Dr. Lim is currently a director of hematology and the chief of the division of hematology and hemostasis at New York Medical College. His laboratory has focused on translational research in the area of tumor immunology. The past 4 years in sickle cell disease, he and his group were the first to propose the notion of the intestinal barrier being breached in sickle cell disease that changes the pathophysiology. I had the pleasure of collaborating with him recently. He's involved also in the gateway, the complication associated with sickle cell disease and the involvement of the microbiome. I look forward to see the presentation today. Please join me in welcoming Dr. Lim.
Thank you very much. I better warn you, I'm very technophobic, okay, so I might be pressing the wrong button. So everything that I'm going to be, the data that I'm going to be presenting are actually funded by Valence Pharmaceutical International. So sickle cell disease is a genetic disorder that affects red blood cells, and it's characterized by a point mutation at chromosome at codon 6 of beta globin in gene, and as a result, the glutamic acid on the sixth on the beta globin chain is being substituted with valine, and this renders the hemoglobin to increase susceptibility to polymerization. As the hemoglobin polymerizes, as the erythrocyte takes up a secret morphology. One of the biggest complications affecting patients with sickle cell disease is vaso-occlusive crisis. Patients present with pain, and histologically is characterized by occlusion of small blood vessels by sickled red blood cells. However, when one examines the peripheral blood smear of patients with sickle cell disease, there seems to be a disconnect between the number of sickled red blood cells and symptoms of vaso-occlusive crisis. Patient A is a patient who came to clinic very well without symptoms, and yet peripheral blood showed that there was a lot of sickled red blood cells. Whereas patient B actually was in hospital screaming with pain, getting a lot of pain medicine because of painful crisis, and yet when you look at the peripheral blood smear, there was very few sickled red blood cells, suggesting that in addition to sickled red blood cells, one actually needs some other cofactor for the pathogenesis of painful sickle cell vaso-occlusive crisis. Neutrophil has been found to be one of the pivotal player in the pathogenesis of sickle cell vaso-occlusive crisis, because various observation has found that, in fact, compared to patients without, or compared to healthy individuals without sickle cell disease, patients with sickle cell disease tend to have higher white cells or neutrophil, circulating neutrophil. Furthermore, in patients with sickle cell disease, the higher the neutrophil count is, the worse are the severity of the disease. In addition, patients who receive hydroxyurea for treatment of sickle cell disease, they appear to benefit from the hydroxyurea irrespective of whether or not there was an appropriate increase in the fetal hemoglobin as long as the patients actually showed a drop in their white cell count. The reason why neutrophils are pivotal for the pathogenesis of vaso-occlusive crisis is that neutrophils are Sickle red blood cells are actually more likely to adhere to immobilized neutrophil than to endothelial cells. So what are the type of neutrophils that actually are immobilized on endothelial cells? The neutrophils that are immobilized on endothelial cells and form the nidus for the adhesion of secret erythrocyte causing vaso-occlusive crisis are activated neutrophil and H neutrophil. Paul Frenek's group a few years ago showed that in fact neutrophil aging is actually driven by intestinal microbiota. What they found was that mice treated with combination oral antibiotics that consisted of oral vancomycin, metronidazole, ampicillin, and neomycin actually had lower number of H neutrophil in their circulation compared to control. Furthermore, mice that were raised in germ-free environment and also had lower number of H neutrophil compared to those that were raised in specific pathogen-free environment. However, the number of H neutrophil actually went up following fecal transfer from fecal material of mice that were raised in specific pathogen-free environment. Using genetically engineered mice, they found that in fact the microbiota-driven neutrophil aging appear to be mediated through neutrophil toll-like receptor 2 and 4 and also MYD88. As some of you know, both toll-like receptor 2 and 4 and MYD88 are actually receptors for pathogen-associated molecular patterns such as LPS or lipopolysaccharides. Based on the studies, it led us to ask the question, well, sickle cell patients have higher neutrophil count. Furthermore, sickle cell patients have higher H neutrophil. And if the intestinal microbiota are the one that actually regulate neutrophil aging, there must be somehow a breach in the intestinal barrier in sickle cell patient in order that the pathogen-associated molecular pattern can interact with the toll-like receptor and with MYD88. With that, we came up with a model for intestinal changes in sickle cell disease. The top panels show that this is the normal intestinal mucosa in which you have a balanced microbial composition that produces short-chain fatty acid and indoles needed for enterocyte health and they also are responsible for the development of tight junction between the enterocyte and also the acetylation of the histone to prevent enterocyte apoptosis. However, in sickle cell patients, as a result of recurrent vaso-occlusive crisis that affects the splenic vasculature, you have hypoxia-induced And it's been well documented that hypoxia actually causes a change in the intestinal microbiome. Furthermore, because of the hypoxemia, there's mucosal damage. So a combination of mucosal damage and changes in the intestinal microbiome on actually that causes changes in the short chain fatty acid production and indole production causes increased leakiness in the intestinal barrier. So with that model in mind, we actually start asking a series of pertinent questions. Question one that we asked was that, well, so if that being the case, what is the evidence for an altered intestinal microbial composition in sickle cell patient? For this, we examined the stool sample from 35 sickle cell patients and compared to 15 stool sample from 15 in sickle cell sickle trait patients. And that we carry out 16S sequence analysis. And we found that although at the level of phylum, we did not show any significant differences between the two groups, but when we look at the microbiome at the genera level, we found that in fact sickle cell patients had a much lower abundance of pseudobutyryl vibrio and LSTPs. Interestingly, both LSTPs and pseudobutyryl vibrio actually negatively correlated with serum LDH, which is a marker of hemolysis. We also found that within the group of patients with sickle cell disease, those who have a higher abundance of Lachnoclostridium actually tend to exhibit features that favor a better prognosis. These individuals had higher hemoglobin level, hemoglobin F level, and lower C-reactive protein, and also lower white cell count. So at this point, this may suggest to us that perhaps pseudobutyryl vibrio and LSTPs together with Lachnoclostridium are the good bacteria in sickle cell patients. So question two that we asked is that, well, in our model, we talk about intestinal injury and gut permeability in sickle cell patients. What's the evidence for that? For this, we actually look at the serum, we compare the serum intestinal fatty acid binding protein and LPS level of sickle cell patients with those of control having the same degree of anemia. Intestinal fatty acid binding proteins are proteins that's produced by enterocyte, and they are released into circulation upon enterocyte damage. And what we found was that there is, in fact, elevated intestinal fatty acid binding protein in sickle cell patients compared to control, suggesting that sickle cell intestine actually suffers injury. In addition, the level of serum LPS was also significantly higher, suggesting that for reason either because there are more bacterial load in the intestine of sickle cell patient, or that sickle cell intestinal barrier are breached, there are more translocation of intestinal bacteria and bacterial products across the intestinal barrier into the systemic circulation. We also confirmed that compared to control, sickle cell patients are more likely to have activated neutrophil as measured by serum CD62L. Having found that, so sickle cell patient has altered intestinal microbial composition, and there's injury in sickle cell patient intestine. The next question, obviously, that we ask would be, well, so are they more likely to actually develop Clostridium difficile infection, since Clostridium difficile infection is a form of microbiome disease? Furthermore, sickle cell patients tend to be in and out of hospital very frequently. And in addition, they always develop fever with the vaso-occlusive crisis and are often given antibiotics blindly for their fever. So for this, what we did was that we carried out a survey of our sickle cell population. There were 106 patients, and it involved 365 hospitalizations. They were young patients with a median age of 26 years. And the average length of hospital stay was 10.2 days, ranged from 1 to 93 days. And that the total number of hospital stay was 3,727 days. And look at this. In fact, there were 454 courses of antibiotics were given during that hospitalization. And in addition, there were 1,984 units of blood transfused to these patients. So these are very high-risk patients for developing Clostridium difficile infection. Yet, we found that, in fact, sickle cell patients had a much lower incidence of C. diff compared to hospital-wide patients within our institution, and also compared to the published data from other institutions. Okay. And this suggests to us that, well, this is actually contrary to our expectation. And if that being the case, there must be some changes in the metabolomics of the sickle cell intestine that actually protects them from C. diff infection. So in order to get a glimpse into the differences in metabolomics of sickle cell patients, we decided to look at their urinary 3-indoxyl sulfate level. 3-indoxyl sulfate is actually a metabolite from tryptophan by intestinal bacteria, and that the elevated level has been correlated to increase in intestinal clostridiols. And we found that, in fact, there's differences in the metabolomics between sickle cell patients and the control, or as shown by differences in the urinary 3-indoxyl sulfate. Now, interestingly, as I say earlier, that there's a correlation between 3-indoxyl sulfate level and intestinal clostridiolis abundance of clostridiolis and that clostridiolis are known to be producer of short-chain fatty acid, including butyrate. And butyrate definitely has previously been shown to actually inhibit the growth of C. diff in vitro. So our results would suggest that, well, the increase in the urinary 3-indoxyl sulfate must be due to either a global increase in the intestinal microbial density without changes in the abundance, or that there's a preferential increase in the in the abundance of Clostridiales. However, when we look back into our data that we did earlier on 16S analysis, we did not find that there was actually increase in abundance of the Clostridiales is in sickle cell patients, suggesting that there must have been a global increase in the microbial intestinal density. Now, what could that have been due to? The only thing that one could think of would be that perhaps in sickle cell patients, you actually have small bowel bacterial overgrowth. And when one think about it, this is not an impossible hypothesis, because sickle cell patients tend to get opioid regularly for their pain. Opioid has been found to actually decrease intestinal motility, and as a result, leading to bacterial overgrowth. We also found that in fact, those patients with higher level of urinary 3-indoxyl sulfate are also more likely to have higher number of circulating H neutrophil. Again, that goes to support the hypothesis that there are more bacteria or bacterial products being translocated into the systemic circulation in these patients. This has led us to propose a model of sickle cell intestinal injury. So in this model, you have the normal intestinal mucosa, and due to recurrent vaso-occlusive crisis, you have hypoxia reperfusion injury causing mucosal injury. And this leads to a breach in the gut barrier, and that causes increased bacterial translocation. In addition, because of the hypoxia, there's a change in the intestinal microbiome, and that appears to favor the increase in the indole producer, and that's the reason why we get elevated urinary 3-indoxyl sulfate, and that the indole producer also produces butyrate that inhibits C. diff proliferation. On the right-hand side, because the patient have frequent vaso-occlusive crisis, they start using more opioid analgesia, and as a result, this impairs gut motility, and that leads to bacterial overgrowth. And as the bacterial density increases, it also increases the amount of bacteria being translocated across the intestinal barrier into the systemic circulation. So what I'm going to do next is I'm going to spend the rest of my time discussing on how can we target the intestinal microbiome in sickle cell patients. I like to actually base it on a pathologic loop that I've come up with that I call the vicious cycle of sickle cell disease. So you have vaso-occlusive crisis, and that leads to intestinal dysbiosis, and in turn, as a result, you have breach in gut permeability, and then that causes increase in bacterial translocation that activates the neutrophil, and again, that feeds back into the loop. So one can imagine that you could actually interrupt this vicious cycle at various points of the cycle. Our group has been concentrating primarily on first reducing the activated neutrophil by reducing the bacterial translocation across the intestinal barrier, and also looking at reducing the intestinal translocation across the barrier by improving the gut barrier. or reducing the breach in the gut permeability. And then by reducing in a breach in the gut permeability by targeting in or optimizing the intestinal microbial composition. So for this, for the first uh, for the first part of this therapeutic intervention, we have carried out a phase 2 study of rifaximin for patients with sickle cell disease. This is on the basis that if we were to reduce the amount of intestinal microbial density in sickle cell patients, we might reduce the amount of bacteria translocated across the intestinal barrier into the circulation, thereby reducing painful crisis. We've chosen rifaximin because rifaximin is scientifically a very interesting antibiotic because it's minimally absorbed, thereby circumventing any question of whether it could be the systemic effect of rifaximin. Furthermore, rifaximin is a realistic antibiotic to be used since it has a long track record of being used long-term for patients with liver cirrhosis. So for this, we accrued patients who have had at least 2 episodes of painful crisis is in the previous 12 months, and that we accrued a total of 13 patients. However, only 12 continued with the study. 1 patient consented to the study but never turned up. This is actually a very common problem faced by investigators carrying out studies in sickle cell disease because this is a very difficult group of patients to work with. But nevertheless, out of the 13 patients, we have 12 patients who are following through with the treatment. Each patient received 550 milligrams of rifaximin twice a day. We found that, not surprisingly, when we look at the changes in the microbiome, we found that following rifaximin, there was actually an increase in the intestinal bacteroides. The significance of this is unclear at this point. Most importantly, we seem to have validated our hypothesis. We set up wanting to reduce the amount of bacteria being translocated across the intestinal barriers so that we can reduce the number of circulating H neutrophil. And we found that in all the 11 patients that we have analyzed, there was a significant drop in the circulating H neutrophil. And with that, we also found that the serum LPS went down following treatment with rifaximin in all patients. Similarly, when we look at the degree of neutrophil activation in sickle cell patients, we found that in fact the CD62L decreased significantly following in rifaximin treatment. Now, probably either due to the anti-inflammatory property of rifaximin or to the fact that the patient were doing better, we found that, in fact, the intestinal fatty acid binding protein also came down, suggesting that there's now less intestinal injury following in rifaximin therapy. So, of course, as a physician, the next question is, are we doing any good to the patient? Now, this is the data on the first 11 patients, and that when we did an interim analysis of the data with a median follow-up of 3 months, and the range of follow-up was 2 to 6 months, we found that 9 out of the 11 patients actually show reduction in their need for intravenous opioid due to painful crisis. So the next part of the intervention would be our attempt to reduce bacterial translocation by attacking the increase in gut permeability. For this, we are starting our study in sickle cell mice. We will be treating a group of sickle cell mice with L-glutamine. L-glutamine is known to promote enteral health and also to promote tight junction formation. And that we will be treating them with L-glutamine or without L-glutamine and then examine in their venous blood for changes in circulating H neutrophil together with gut permeability. And finally, we will also sacrifice the mice and look at their intestinal tight junction by immunofluorescence for changes in the tight junction density. Finally, for in part 3, we will be looking at how do we improve how do we reduce gut permeability by actually changing the intestinal microbial composition. For this, again, well, first you may remember I said earlier that perhaps pseudo-butyrivibrio and Elistipes together with Clostridium may be the good bacteria for our sickle cell patient. So we will be testing this individual bacteria in our sickle cell mice by doing bacteria transfer using gastric lavage into sickle cell mice. And then after that, after establishing that the transferred bacteria has engrafted, we would be challenging them with TNF alpha to see whether or not to look at survival due to vaso-occlusive crisis. Now, obviously, the other experiments that we would be doing would be, in fact, to do a whole fecal transfer from sickle cell mice to see whether or not that actually provide them or confer them the protection against TNF alpha induced fatal vaso-occlusive crisis. So in conclusion, we found that intestinal pathophysiologic changes occur in patients with sickle cell disease. The altered intestinal pathophysiology is likely the result of a combination of intestinal injury due to vaso-occlusive crisis and also the use of opioid. Although the altered intestinal pathophysiologic changes appear to confer some protection against C. diff infection, it also fits into the vicious cycle of sickle cell disease. And definitely, the abnormality in the intestinal pathophysiology provides us with the opportunity to come up with novel therapeutic approaches for sickle cell disease. I'd like to thank the following who has contributed to this work: Alison Morris, Barbara Matthey, and Kelvin Lee at the Center for Microbiome in Medicine at the University of Pittsburgh, University of Nebraska Medical Center, where Stephen O'Barrow is, and also Dibiandu Datta, who is my postdoc. Thank you very much.
Thank you, Dr. Lim, for this stimulating presentation. Are there any questions? Yes, please.
Very interesting talk. Another pathway of neutrophils that's involved in inflammation is neutrophil netosis.
Yeah.
does the intestinal changes you describe
Hmm.
affect neutrophil netosis, which could be pathogenic as well?
We've not looked at that, but definitely Paul Frenek's group has looked at netosis and found that, well, they just looked at netosis in sickle cell patient and then found that, there was increased netosis.
Hi. So you observed that the use of opioids slows the intestinal motility, causing an increase in bacterial culture there. And earlier we heard from Ari that the secondary bile acid rich environment
Yeah.
helps prevent the C. diff infections. Have you confirmed a high concentration of secondary bile acids as a cause for the reduction in C. diff?
No, we've not. And that's something that we'll be looking into. In addition to actually, one of the things that we are actually planning to start looking back onto the specimen is to do the quantitative PCR for the 16S gene copy number to actually confirm that, in fact, the microbial density is actually increased.
Any other question? Thank you, Dr. Lim.
Thank you very much.
Our last speaker is Dr. Gurudut Banavar, who's the CTO of Biome. The conference is partly sponsored by Biome, as you saw in many other slides this morning. It's a company that offers a unprecedented visibility into the biological ecosystem. When you're in the microbiome space, if you don't say ecosystem, then you're not in the game, basically. Inside each of us, and deliver personalized diet recommendation to affect and change chronic disease. He is at the company's mission to develop a artificial intelligence-based health solution by extracting insight from the molecular data, such as the poop, metatranscriptome, and the human blood transcriptome. He's here to talk to us about a new platform of an app that they have in regard to providing, based on the analysis of the, I believe it's fecal samples, give you valuable information as to what is good for your diet and what is not good for your diet, and using this as a springboard basically to take it to the next level with diet recommendation and even therapeutics interventions. Thank you.
Thank you so much, Dr. Amar. That sounded more like marketing than anything else, right? But yes, so I represent Biome, one of the co-founders, and I want to say that this is a 2-year-old company which got started with the vision of a bunch of scientists and technologists, one of whom came from the Los Alamos National Labs, which has been doing a lot of work in bacterial science, if you will. And my own heritage is from IBM Watson AI, which is not too far from here. And so I come from the analytics and application of many kinds of algorithms to very large data sets, which, as you heard today, the microbiome data sets are, in fact, one of the most fascinating data sets that you can have. The other thing I want to say is that I want to leave you with a message that this platform that we're building is ready for very large-scale applications and collaborations with clinicians such as yourselves. And when I say large-scale, I'm talking about tens of thousands of samples. We currently already have more than or almost 50,000 samples, human samples of stool that we get when people purchase our service, when they get this kind of a kit at home. And you can see a card that's right in front of you right now. There's a very cost-effective way of getting samples and turning that into very high-resolution data that I'm going to talk about, enough to be able to do a variety of different analysis based on metadata that we get through an app, which is on your iPhone or your Android device. And also, we are doing a number of clinical studies that have much more robust clinical annotations, so to speak, or clinical labels associated with them, so we can apply those studies, which generally tend to be in the thousands of human samples, back into the, hopefully very soon, tens and hundreds of thousands of samples that we're going to have. So let me get started. I am very happy that a lot of the discussion already shows that there are associations between the microbiome and pretty much every major chronic disease that you can imagine: pancreatic cancer, colorectal cancer, a number of different neurodegenerative diseases like autism. You've seen issues with Parkinson's, and those kinds of correlations have been made. Here we talked about obese mice, but there's also correlations that have been made with human obesity, which I'll in fact talk about. Non-alcoholic fatty liver disease, there's been associations with that. Depression, quality of life, huge amounts of work done in there. Also ankylosing spondylitis, all kinds of arthritis, and inflammatory gastrointestinal diseases like inflammatory bowel disease and irritable bowel syndrome and so forth. These are kind of some of the sort of biggest results that have been already shown. But one of the things that I take away from it, and the basis on which we built this company, is that all of this science obviously talks about an ecosystem, like Dr. Amar talked about, and we need to understand that ecosystem in order to be able to do something about it. But a lot of the factors in that ecosystem are controllable. And the idea of the diet and lifestyle and the environment being extremely important factors in the controllability of this ecosystem is the primary hypothesis that we are studying at this time. And fundamentally, we think of gene expression as the knob, if you will, that you can turn by using all of these controllable factors. So essentially, we are making a bet in this company that gene expression, which is essentially metatranscriptomics, as one of the previous speakers talked about, is the fundamental sort of switch, or thousands and millions of switches actually, both in the microbiome as well as in the host, that can in fact take us to the next level in terms of managing and in fact deterring chronic disease. So this audience knows a lot more about the biology than I do, but what is apparent already, very, very clear in the community, is that gene expression is the factor that, once it goes off track, causes a variety of diseases. We looked at kidney diseases, we looked at intestinal diseases, we looked at inflammatory or autoimmune diseases. All of these have some irregularity in gene expression. So, like I said, the bet we're making is, let's study the RNA. So we built a technology pipeline which is highly reliable and scalable. And by scalable, what I mean is that it's low cost, which is a couple of $100s, as opposed to what you might get from a commercial lab service, which could be a few $1,000s. And it is very high throughput. In other words, with a couple of shifts, we can literally do 1,000 samples per day, right? So this is a very highly scalable system. So we lyse the RNA. Once we get the sample, of course, we do the sample preparation steps, and we remove the non-informative RNAs. So we keep the mRNAs, and there's a whole bunch of patents around the small box that you see down below that we got exclusive rights from the Los Alamos National Labs, and that was invented by one of our co-founders, through which we use these streptavidin beads to bind to the non-informative RNAs, or non-informative, of all kinds. We have the rRNAs and the tRNAs and some mRNAs, which are then pulled out, and only the informative RNAs are then enriched by almost tenfold, and then they are multiplexed using standard barcoding techniques, and then we outsource the actual converting to data, the sequencing itself, with the Illumina machines and so forth at many different institutions that have an abundant capacity to give us low cost sort of commodity type of sequencing data, and which once we get the BCL files back, we then do the bioinformatics to be able to identify both the taxa, the organisms, through a number of techniques that are in the literature. In fact, there's a lot of open source software through which we can get a huge amount of accuracy in terms of the aligning and the sequencing to the genomes of more than 100,000 organisms, microorganisms. But more importantly, in my mind, it's not about the taxa, it's about the functions. So the functions as in what is being expressed, what are the genes and the enzymes that they code for, what are the activations of the pathways that are associated with a variety of different phenotypes is what we are ultimately interested in. So we focus a lot more on the gene side, look at all of the mappings to genes and also the KEGG orthologies that was previously mentioned today as well. And even more importantly than the KEGG orthologies, which are already clusters of functions that are put together, we look at pathways. So as you all know, the pathways have many complex topologies, but we can look at specific metabolites that are of interest to us and see how far the expression of specific genes that we see in our analysis have enabled those pathways, and how can we quantify the pathway expression itself and associate that with the phenotypes that we get from our customers. So first and foremost, I have to convince most people that RNA analysis, RNA sample prep is in fact reliable, because a lot of people have this worry, which is justifiable, that it's not very stable, and also that the reliability of the entire pipeline, starting from the sample prep all the way to the bioinformatics, is reasonable. So one of our papers that we just published a few months ago basically shows that when you do intra-sample variability analysis, that is, with the same stool sample, if you take different portions of the stool and see what the variations are, the variations are very low, which is the top left. And if you take the same stool samples 0, 3 minutes, and 10 minutes after production, and you check for variability, again, you see low variability on the taxa side and on the gene side. Again, these are all in the paper, and there's a lot more detail in the paper. And if you also look at the variability of the transcriptome or the metatranscriptome at the period of 0 weeks, 1 week, and 2 weeks with the same general diet across a number of participants, you see also low variability. So you get some stability with respect to the metatranscriptome. And finally, I think the really big question that a lot of people have in their minds is, if you can store and ship these samples, once you get these kits, you can ship them from wherever you are in the country, and now it's actually in multiple countries, in more than 12 countries now. If they ship it to the lab, will the RNA molecule survive that length of time? So we've shown basically that the variation at time 0 versus time 0, and the variation at time 0 versus 4 weeks at room temperature, and 4 weeks at room temperature after shipping, which is going through all of these variations in the shipping process, the variability that you see for both taxa and genes, which is the blue and the orange blobs that you see up there, those are fairly tight. And the variation that you see from one case to the other 2 cases are well contained. And we've tested this across many different kinds of samples, different types of locations, and so forth. So this paper, basically, this is currently a preprint. It's just been accepted in a journal. It's going to appear in a peer-reviewed journal. It shows for the first 10,000 samples. 10,000 samples. So we are talking here very, very large numbers, right? For the first 10,000 samples, how our analysis has fared, and what are the top taxa that you see on the left-hand side, the genera, the species, and the strains, and the top genes that you see in this first very large sample. And at this point in time, we're almost 50,000 samples, as I said. So the number and the scale is going up very, very fast. The one key point I want to make is that this particular pipeline, which we call Biomega, is very high resolution. So we go all the way down to strain level resolution, and it also is much more focused on functions, which is the chaos, the KEGG orthologies, and of course, ultimately, we want to get to the pathways. Now, when I talk about pathways, there's a bunch of things that I need to talk about, but let me summarize this segment of the talk by saying, when you compare the 16S processing, which a lot of microbiome research has focused on for the last 10 years, versus the more recent metagenomic, which you can think of as sort of the second generation. And I think of the metatranscriptomic process as the third generation. I would claim that there are many advantages of the metatranscriptomic methodology, which starts off by saying, first and foremost, you see the activity of what is going on in your microbiome, not just the potential. One of the questions I asked earlier speaker is about, what do you see in terms of variation across time? And we now have some data that shows that across time there are some pretty significant changes, and and I don't have that particular talk right now, but I can happily talk to you offline about that. But you do see changes in activity, so that's the key portion. The second thing is we quantify the all microorganisms, which is the RNA, viruses, the phages, and of course even the eukaryotes and the bacteria and the virus and so forth. And finally, we also quantify biochemical solution, the biochemical activity that's going on, right? So it's ultimately about the pathways, as I've been saying. So let's talk about biochemical activity. So how do we do this? We have a number of algorithms that have collected the best known functions of organisms as well as pathways in the literature and created a number of pathway expression level scores. So the kinds of pathways we look at, we've talked about butyrate quite a bit, which is a very well-known anti-inflammatory type of a metabolite, and there are butyrate pathways that is very easily seen to be active in the microbiome. So how do we see that a butyrate pathway is active? So on the right-hand side, I give you an example of how that is seen. So you see here there's many different kinds of carbohydrates that can go down multiple different pathways based on a number of different species or all of these enzymes and genes that are along the pathway. So the ultimate site of production of butyrate is all the way down at the bottom. But if your genes that we see or detect in your microbiome is close to the site of generation, then you can consider that the pathway is likely very active. If a gene or enzyme is further away from the site of generation, you can say it's maybe moderately active. But if it's far away from the site of generation along the pathway as we know it, it's probably low level of generation, right? In addition, we look at the abundance or the activity of multiple species and other genus and strains of organisms that are known butyrate producers. So when you collect all of that information into one metric, if you will, or one score that says here is the overall expression level of butyrate production pathways. So that represents the first bullet on the left-hand side. And we do the same thing for LPS. We do the same thing all the way down. We talked about bile acids, both primary and secondary bile acids. We have scores for those. And we literally have hundreds of such scores, which are all functional categories that are active within your microbiome. And then we aggregate them even further because, remember, this is a consumer level product right now. We aggregate them even further into inflammatory activity, metabolic fitness, digestive efficiency, intestinal barrier health, and so on and so forth, which combines all of these pathways and says, using the best known knowledge of the community who has done the research over many years, we are able to provide a general level of effectiveness of a particular function within your body, such as inflammation or metabolic or digestive or intestinal barrier. So these are the kinds of scores that we currently show in our app, or currently or very soon to be showing. So if you subscribe, you will end up seeing a number of these scores in your app as one of the first things that you'll see. Now, this is top down, meaning this is knowledge driven based on people's expertise. We also look at the raw data, just the genes, and we cluster them using many different algorithmic techniques. This particular one applied a number of sort of dimensionality reduction techniques as well as coloring techniques for the clusters and so forth. And we are able to see that even from a bottom-up perspective, there are a number of clusters that automatically give us certain phenotypes that are of interest. So for example, you can see that on the right bottom, there are two clusters, one of which shows that one of which says that it's less likely to have had diabetes, and the other one shows that it's more likely to have had diabetes based on self-reported diabetes diagnosis. So if we ask people, out of the one of the almost 300 questions that we ask when every individual in our customer base joins the service is, what kinds of medical history do you have had? What are your preferences in diet? What are your symptoms right now? What is your ancestral kind of pattern, right? What is, what kind of environment do you live in, do you work in, and so forth. So there's a whole range of questions that we ask, which becomes the metadata based on which we do this kind of bottom-up analysis, which ends up giving us this kind of unsupervised clustering, which becomes a basis for putting down hypotheses that we can start to build predictive models for. So I want to go from what has been mostly talked about in the microbiome literature, which is association studies, to predictive modeling, which is if I build a predictive model, a machine learned model with known labels, can I predict for an unknown data set, can I predict what their correct labels were? And we can always test the accuracy of whether or not we can do that based on many standard techniques like K4 cross-validation, for example, or other kinds of techniques. So I'll talk about many of those, but let me start with one of the very direct consequences of microbiome, right, which is bowel movement, right? So you see here there are two clusters. One of them says it's much more likely to report constipation. Another one says that much more likely to report diarrhea, right? It's two extremes of bowel movement patterns. So we picked up on those phenotypes that kind of surfaced automatically using our unsupervised learning, and tried to see what is, can we predict this as using a classifier. So here's a distribution of all of the, we created a constipation score. So lower and higher. Higher is highly constipated. Lower means diarrhea. So can we predict the two extremes of this distribution using standard classifier methods? And it turns out, with about 75% ROC AUC, we can predict the two extremes by looking at all of the RNA, the active pathways, and the active genes and the active taxa. So we combine all of those features together in these predictive models. We can also predict, turns out we can predict your age just by looking at your microbiome within 10 years, within a decade, which is pretty good. And I suspect that as the data set grows, that this accuracy will probably increase over time. But let's now go into not just sort of single point phenotypes, but something which is much more of a systems biology type of a phenotype, which is your glycemic response. So we just have a paper out last month which says that we can predict your glycemic response based on a combination of your overall physical phenotypes as well as your microbiome put together. And it's pretty surprising results. You might think that your glycemic response is fundamentally based on just the food that you eat, but it's not just the food that you eat. It's a combination of the food and your physical body, which includes your microbiome. And specifically, what we ended up doing is we collected data from 550 participants in a study with a continuous glucose monitor over a period of 14 days. We gave them specific foods to eat every single day, and we collected the response over the 14 days. And ultimately, we ended up having 27,000 meals for which we knew the exact glycemic response. And the distribution of macronutrients for those meals are given in that triangle picture on the left-hand side, where the red ones are free meals. People can eat whatever they want. And the blue dots are provided meals, which are pre-designed meals, which have specific distributions or proportions of fat, carbs, and proteins. So when we fuse all the data that we get from a person, you see the top two bars, which shows that the blue line is the glycemic response. You see a meal, which is a vertical line. When the meal happens, you see the glycemic response go up. And when they eat another meal, it goes up again, and so on and so forth. There's a baseline glycemic response. You also see their activity, which is the small red bars. You see their sleep patterns, deep sleep versus light sleep, and so forth. We get all the microbiome, samples up front. We also get, of course, the macronutrient content of the individual foods. And remember, there are 27,000 meals, but there was 9 specific meals that we repeated. And those are the 9 meals that I show in the table at the bottom. And the specific IAUC, which is the incremental area under the curve of their glycemic response, and the range of the IAUC that I show here for the blue boxes, those are the same meals that we did multiple times, because we wanted to see what the intra-person variation is for a given meal. And so you see the full range of glycemic response for any given individual, and using that, we can have some very interesting observations. So I picked one particular sort of anecdotal example just to demonstrate how this model, this machine learned model, can predict your glycemic response. So on the left side, you see the observed glycemic response. So it turns out that there are these 2 individuals, P3 and P4, who have exactly the opposite response for 2 meals, banana and bread. So one person eats banana, the glycemic response shoots up, but when they eat bread, the glycemic response stays pretty much flat. The other person eats the same 2 meals, bread shoots up, and banana stays flat. Now, that shows that there's a tremendous amount of personal physical variability, including the microbiome, that determines this glycemic response. That's what we observed in our raw data, and we have 27,000 such observations. Remember that. So using those observations, we built a model, and then we predict what the glycemic response is likely to be. On the right-hand side, you see our predictions, and I picked, just to demonstrate this point, 10 random people for whom we predicted the glycemic response, and on the x-axis I have the carbs, and the y-axis I show the glycemic response. And I want to draw your attention to the blue curve. I hope you can see that. It's kind of starts very low and it goes kind of high. And there's a red curve which starts a little bit higher and it goes low when you vary the carbs content for a given meal. So in this kind of a graph, consider 2 meals, meal A and meal B. Meal A turns out to be about 25 grams of carbs, which is similar to the bread meal that we gave these individuals here. And meal B is similar to banana, which is about 50 grams of carbs, which we also gave to the same individuals here. And when you look at their predicted glycemic response, you see here, this is the point at which the red curve and the blue curve actually cross over. So on the left side for meal A, the blue curve, the blue person, which is similar to P3, has a lower glycemic response than the red person, which is P4. And for meal B, the red person has a lower glycemic response than the blue person, which is P3. So what this shows is that there is tremendous variability to individual meals across individual people, but our model is in fact able to predict that in a non-intuitive way. I mean, you cannot get this just by looking at the meal or just by looking at the person. This can only happen when you collect huge amounts of data and you're able to build a model that mathematically gives you these answers. So that's the point of this slide. And there's a lot of statistics and machine learning terminology in this paper. I welcome you to read that. And this shows the performance of the model. And the key point here is that when you simply look at carbs, the performance of the model is not very good. This is kind of standard clinical practice, right? You look at meals and you say, eat a low carb meal, and that's not good enough because the the glycemic response on the y-axis, you know, compared to the actual glycemic response for those meals, very different, very low correlation. Whereas in our predictive model, which includes all of the other features, which includes your age, your BMI, your microbiome, and all of the other features that are shown in this picture here, then you get a much more accurate prediction of your glycemic response. So we have incorporated all of these features in our model, and you see the blue features are your microbiome features, and those are actually pathways. You show here, there's a fucose metabolism pathway, and you know, probably many of you will know that, you know, the fucose pathways get activated when somebody, you know, has, you know, fucose in the lining, or when they eat particular kinds of food. There's an indole acetate production pathway. I was happy to see that, you know, indole production was mentioned in one of the previous talks as well. So that production pathway is positively correlated, meaning that if your pathway is more active, then your glycemic response is lower. I should probably say it's negatively correlated. Fucose metabolism, if you have more fucose, then you have higher glycemic response, and so on and so forth. So all of those correlations are represented in this mathematical diagram here. I'm going to call this the signature, the microbiome signature for that disease. But in this case, it's a phenotype, which is glycemic response. Okay, so that glycemic response module is one module out of many modules that goes into a recommendation engine, which gives you your food recommendations when you get the service in your app. So in the app, you know, you have your kit, gives you the gut microbiome, you answer your questionnaires, and, you know, based on our food ontology with our meal data, we have incorporated a number of glycemic response, plus we analyze your phenotype, plus we do some other molecular pathway analyses, and we can look at your activity and your sleep when available. We also currently have a food sensitivity kit, which is addition to this, and a blood transcriptomic kit. So that gives us the ability to see the interaction between your microbiome and the host, blood transcriptome. So this is a brand new product that is just coming out in the next couple of months. The food sensitivity just came out in the last couple of weeks, actually. So putting all of that stuff together, you get foods and supplements in your app, just out there, you know, in a very simple form that you can keep in your pocket and use whether you cook at home or you go to a restaurant. So what is our overall approach, stepping back from all of this? Or what is our overall approach to all kinds of chronic illness, right? So glycemic response is just one part of it, but let's step back and see, how do we address all kinds of chronic illness? So just 2 steps. We identify the microbial signature associated with a disease state, and that's what we get from the studies that we are talking about. And this is an example of a microbial signature. And then based on that, we deliver personalized foods and supplement interventions to rebalance your microbiome towards a healthy state. Now, what does that mean? If we don't see a particular type of pathway that's active, which means that you probably do not have those organisms, we can add the bacteria from food or supplements. So that's a probiotic. If we do see the organisms, but we don't see them being active, that means they're there, but they're dormant. So we can add a prebiotic. So feed the bacteria, get them more active. But if we don't see any presence or any availability of bacteria at all, then we could kickstart by giving you the metabolite directly. In the case of butyrate, for example, we could give you a butyrate supplement just to get you started. And in the meantime, you can also add the the probiotic or the prebiotic to kickstart the rest of your microbiome and rebalance things, right? So that's the kind of logic that we use today to get some of the initial food recommendations and supplement recommendations over to the masses, basically. But eventually, we want to be able to do this for specific disease states. So the first question for us was, can we even identify the microbiome signatures for commonly addressed diseases, right? So we picked the most common diseases. In this case, 4 diseases that represent probably 50% of all chronic disease on the planet, which is IBS, depression, type 2 diabetes, obesity. put it together, it's probably 50%. Now, for those 4 diseases, we have these kinds of study cohorts, like about 500 disease, 500 healthy, 500 more or less. And each of those, we have a predictor today, which is able to get 20 points, up to 20 points above baseline. Baseline is just the sort of the majority predictor, which I think is a great start. So going back to the previous picture, which that means that we have the microbiome signatures associated with some of the major chronic diseases that are prevalent today in the world. So the next question is, how do we deliver personalized foods and supplements? And that's where I would like to work with you all on. Okay, so today we have a number of clinical studies that we would like to perform for the diseases that we know we can detect with our very large data set. But we want to do interventional studies for all of these diseases. And we have started collaborating with a number of clinicians at NYU, at Memorial Sloan Kettering, Weill Cornell, et cetera, in the city. We are in Manhattan. But we are very much open to having additional collaborations for any of these diseases to first, of course, validate that our microbiome signature that we detect in the data is really seen over and over in an unseen population, but that may be coming to your clinic or to your research lab, and then to test whether those interventions actually work. So that's essentially the last slide. So I'm going to stop there. Thank you very much, and I welcome collaboration.
Everybody, people will have the glycemic index if you continue like this, not being attended properly. If I can have the speakers join me for a little bit of a discussion, I would appreciate that. Dr. Lim just went out. Please, just for a few minutes. I'm going to challenge you and the audience specifically to develop a little bit of a form of a strategy based on what you've learned this morning, heard, and knowing to the microbiome. Where do you think this space should go, and where should we invest the most brain power, money, and industry academic hybrid interaction? So I leave it so that we can basically spend the last 15 minutes brainstorming and seeing. You can join us. No problem. To see how we can brainstorm and see how this space, this interesting space, can serve our interest and being able to springboard to multiple projects. So I open the discussion to the audience with all your questions, and the panel is here, at least for whatever remains on from our panel this morning. Yes, please.
There's some very ubiquitous confounders.
Identify yourself.
Paul Manza, Environmental Health Counselor. I think there are some very ubiquitous confounders like disinfectant byproducts, Bt toxin, glyphosate, et cetera, that would really be confounding to everything that's going on in the microbiome research. And I don't see a lot of thinking and adjustment for that kind of environmental insult, so to speak.
Yeah, first of all, I agree with you. I mean, there's this the design of the studies to prevent confounders has been one of the most difficult parts of all the analysis we've done. So, in my opinion, the control population that we test against for each of these analyses is probably the most important design criteria for managing or getting past the confounders, right? And because of the number of variables we have, literally we have 10,000 variables in each one of these analyses. I don't think we can get to a balanced control versus disease population until we have 10 times 10,000, which is 100,000 samples, which, we may be able to get to in the not too distant future. But I think the problem space, I think, suffers from, high dimensionality problem, if you will, the curse of dimensionality, I guess. So the way that we are dealing with it at the moment is to identify the most significant features that are likely to impact the disease state and ensure that there's balance between the control population and the disease population to minimize confounders. That's the only way that I'll put it right now. And Eric or anyone else, if you have any thoughts about sort of the chemistry of this, Eric is my colleague who has joined me as well. You can join. Otherwise, we can move to the next question.
I think the field is in the, like we call it, development. We've seen this. You remember during the Clinton administration and the genome sequencing, where we just went into sequencing and sequencing and sequencing, not knowing exactly what we were doing. And I'm guilty of the whole of that. But at the end of it, I did put some controls and made sure that the data was coming out properly. And so I think that the field is in development. We are going to be forced to make sure that our controls and positive and negative controls are going to be in place to be able to deliver some interesting formulation. Yes.
Ed Lagama from neonatology. One of the things that's common, at least in the neonatal field, is something they'll call the Barker hypothesis, that neonatal exposures predict subsequent adult diseases, whether it's hypertension or cholesterol problems, et cetera. So clearly the colonization of the newborn is acquired from the mom. And it's really a signature combination of what both parents give to the gut mucosa to allow initial colonization, subsequent modification. So there wasn't much discussion about that kind of an idea, that a lot of what may be becoming an adult disease may actually be initiated in the newborn period. And just as a plug for some work that we've done, we've shown that colonization of the gut after birth, and what we think is related to a butyrate production, actually accelerates catecholamine synthesis and provides a selective survival advantage by allowing better responses to hypoxia or hypoglycemia, because the sympathetic nervous system can produce more catecholamines. So I was wondering if you had any thoughts about that type of a topic, Barker hypothesis, and whether or how the gut flora may alter things like immune function, or in the case you have a slide up for autism, how you get the signal from the gut to the central nervous system.
Would you like to go on? I have some thoughts, but please go ahead.
Probably the gut microbiome, how people have the gut
Oh.
The bacteria can sense some neurotransmitter. And another way is the bacteria may degrade or activate the neurotransmitter. I think this is like the gut is like the manufacturer side for good for the pharmacology. Study the gut bacteria can do a lot of things. From I don't have the neural disease, not my field, but when we study the bacteria in cancers, we found those bacteria in the oral cavity, some can degrade the carcinogens. If you put the carcinogen incubate with bacteria, it disappears. But some other bacteria can, activate the carcinogen and to put like a hydroxy group and to make it more potent than the original form. I think the bacteria is like a greatest chemist. It can do a lot of things we don't know how to do.
I will just add that we are doing, first of all, I strongly believe in this hypothesis based on all the literature that we've seen. We're doing 2 studies that may be of interest to this topic, and it's an open question in our data set at the moment. But one study is going to be, we take a monthly sample of the stool for the first 18 months of a baby. And we're doing this with another company. And there'll be probably about 1,000 cases. So that's something that I'm really looking forward to seeing. So that's number one. Number two, we are doing an autism study with an organization that has 4,500 kids with autism, again, both before and after certain kinds of therapy to see what the effectiveness was and what the changes in the gut microbiome was. Again, I believe that there's a strong correlation there between activities of certain pathways like serotonin, GABA, and others. So in the next 6 months, we should have some 6 months to 9 months, we should have some actual results to share in the space, but very exciting areas.
Yes, my question to the panel is that as an individual, we are always under the influence of different environmental conditions. Not one stage is similar to the same. You have stresses, you have different food. You're not going to be just eating the food as very specific. So how would you then say the normal microbiome of an individual? How would you determine that? Do you have a predictive modeling for that?
I'm going to take this one because it's very dear to me. We did the oral microbiome, and we looked at the mouth microbiome, the oral microbiome, especially on the condition of healthy people versus people that had periodontal disease. And we sequence, and it's very, very complex to being able to determine. One of the questions that we had also for the technology was how do we exclude the mammalian DNA versus the bacterial DNA. We got around that. But what became very clear is that when it comes to healthy people, there's multiple ways of being healthy. You cannot say firmly, this is healthy versus this is not healthy. Then you will see a multiple combination of people coming up in those panels for the analysis with different type of microorganism as to being healthy. That is a challenge by itself. What is a less of a challenge is that there are multiple ways of being healthy, but few ways of being diseased. And that's the advantage that we have. You will, despite of the microbiome, despite of our endeavor, those bad bugs are going to reemerge. And not only they're going to be reemerging, they're going to be responsible for hijacking the opportunistic microorganism. So that probably is going to remain. The challenge that I'm opening based on your question is, can we define the large population of the healthy being dominated by a various combination of microorganisms that do or have little to do with disease? Yes.
I would just agree with you with just based on the large data set we have. I would agree with him that for a given disease, there is a microbial pattern or a signature that we can determine. But healthy in general has been very, very difficult, even with with our very large data set. And we'll keep looking for it, but I don't think we've seen anything like it so far. Yes. Yeah, that's correct. Yeah. Yes, correct.
So as far as future directions for the field, just looking at all the different presentations, I mean, my name is Tim Hyde. I'm from a company called Biocrates, and I'm biased because we have metabolomic kits and services, but all of these studies are begging for metabolomics. Metabolomics simplifies the number of data points that you will need for your analysis because you're not looking at tens of thousands of genes or transcripts. You're looking at a set of maybe 500 metabolites. And I think metabolites can also tell you what the bacteria are doing. Most bacteria are going to have very similar metabolism. However, some particular species will have differential metabolism, and you can easily see that with metabolomics. Finally, it's the closest to the phenotype. The small molecules that are in your body are what are causing your phenotype. So I just wanted to point out that metabolomics is definitely a good future direction forward for microbiome
I
research.
completely agree. The only
is important, but now it's compared with the other analysis. I know the metabolomic analysis is very expensive. It's cost like $500 per sample, right? But for the $500, you can do your microbiome profiling is like 3 times for that's
Well, the only challenge I will put, I mean, just not to be agreeing with everything, the only challenge I would put in there is that once we build good models that associate a method like the metatranscriptomic analysis, which is much cheaper, with the right kinds of metabolite generation, we might be able to predict the metabolite generation directly through these models instead of having to actually detect the metabolites. But this is a discussion we can have offline.
Yes, Irene Grant, infectious disease, specializing in immunocompromised hosts trained at Sloan Kettering. I keep on wondering how much of yeast and fungi are included here. And can you hear me?
Yes.
And it's also known in infectious disease, based on the immune injury, whether it's neutrophil or lymphocyte or AIDS or whatever, it's a completely different microbiome. For example, AIDS patients, their predominant injury results in fungal disease. And what does candida in the mouth do to the bacteria, etc.?
I don't really know the answer, to be honest.
I don't know the answer. I'm just being provocative.
In your data set, because you did metagenomic shotgun sequence, are you able to find the normal, the mycotic microbiome, like the fungal microbiome?
Yes.
Do you see there any patterns predictive to any of those, the metabolic states?
Yeah. Well, I have to get back to you on this because I don't have the data with me right now. But that's a great question. Do see various kinds of pathogens.
Right. From our experiences, we also do the shotgun sequence. It's a little bit technical challenge to analyze the fungal DNA because many of the housekeeping genes are very similar between the fungal, the gene and the human genes. It's very hard to set up the cutoff. You cannot tell which especially many times our sample contain both human and the microbial genes. But you're probably still able to, but you need lots of the computation, expertise in order to figure out.
I can get back to you about it.
Along the vein of using the, yes, Timos Pietris, not a scientist, unfortunately, but very interesting talk today, or talks rather. On the point of using the microbiome for predictions, how are you guys, and how is the field, more importantly, leveraging other testing and other types of testing to create a more of a mosaic to predict certain disease?
So the way that I foresee this field, the microbiome field, using, for example, an inflammatory assay like IL-6 and IL-8 and 9, all of those, is to build models with the right lab ground truth, if you will. Right. So, for example, if I see that there's a certain set of pathways in the microbiome that are always active when you have high TNF alpha, then I might be able to do my analysis on the microbiome to predict TNF alpha rather than to go to the lab and spend $800 or whatever the number is for doing an immunoassay. Right. So that's how I see, building a number of different models to match against a ground truth and then using a low cost, high throughput test to be able to detect many of the markers that exist in the market today. And whether they're disease specific or they are specific, metabolites. I think we can do the same thing for both.
What's interesting is that, if I understand you correctly, we are coming up with a constellation of assays that are making themselves to the clinic and using, in a sense of immune and microbiology or host parasite interaction, a constellation of tests that are going to help the physician to sharpen their diagnosis. there's going to be a microbiome testing or microbiology testing along the testing of antigenic response, because that's goes hand in hand. And with that, when you have an antigenic response against a microorganism, you know that with the bacteria being present and with the immune system being developed, then proper intervention needs to be played. So you are going to have together a constellation of tests that will help defining and sharpening a diagnosis, but also tailoring. And it's important to understand that tailoring the therapeutic intervention.
Hi.
For this type question, I have a question for you. In your stool sample, do you also see human DNA or human RNA? Do you analyze the interactions, the networking, the correlation between the human expression and the bacterial expression? That's probably to give you more clue about how the host bacteria interaction.
Yes. So great question. So just in terms of the presence or activity of human RNA in the stool, we do detect it. Usually it's in very tiny quantities. When it gets past 1 or 2%, we know that there's some serious shedding going on in the intestinal lining, and there's probably some kind of inflammation and probably leaky gut, of all kinds of things, right? So that is included in our intestinal barrier health score. It's one of the elements of the overall score of intestinal barrier health, but it also includes other pathways that are active in your microbiome or not active in your microbiome. That's included in there as well. And the second question is in terms of analyzing the host microbiome interactions, the current approach that we want to use is to have a blood transcriptomic kit. So there's a finger prick blood that you send over to the lab, and we study your active transcripts in your blood. And then we use the active transcripts in your microbiome and the active transcripts in your blood and see what the relationships are. That's just coming out in the next couple of months. And that's going to be another kit on top of this. Again, high throughput, high scale. And then I think that combination will probably be sufficient to do a lot of the chronic disease that currently, I think even the standard of care is not probably very, very high. Yeah. Absolutely. Absolutely. Yeah.
Another question about we are interested whether the gut microbiome can predict the sex or gender. We use the gut microbiome project data, and we are able to have a 66% of chance to predict the gender. So 76 better. Yeah. It's how I thought it's obvious, but it's actually not very easy. Yeah, right. Yeah. Yeah. Another question is, so you are doing the biome kit that analyze the gut microbiome. Are you thinking about to step into the other body side, like the oral microbiome?
Oral is the next step, but it will probably take another 6 months before it becomes a product like that.
Oh, I see. Yeah.
That is the next step. And I'm sure Dr. Amar is very interested in that as well.
Yeah. That's very helpful.
Thank you.
So I have a question. Paul Anaboldi, I'm in the Department of Microbiology here at New York Medical College. How much does region come into play with variability in the microbiome here? Because what's a healthy microbiome in New York may be very different than California, where everything causes cancer, or Europe or Southeast Asia and so forth. And how do you factor that into your analyses? Does that come into play? Because if you have you're trying to develop, what is potentially normal versus a disease state, how much does having a population from one particular area potentially skew toward results towards, one, bacteria versus another?
Yeah, so one of the small things here that you may not have noticed is that in one of the clusters, it says more likely to be Southeast Asian. There were many other such phenotypes that were apparent in these clustering algorithms, which I did not include just because it would become very crowded. But we can, in fact, see in our bottom-up clustering algorithms that people who are from the US versus people who are from Asia cluster differently. So there is some signal there based on the region, but there's a lot more depth we could go into just on that one topic if you're interested. But that signal exists for sure.
Any other question? Hearing none, I will use my prerogative to close the symposium. Thanking everybody, you for this wonderful participation, the speakers for coming in a very genuine way to deliver an interesting message, and I'm looking forward to future conferences here at Dana Road. Thank you very much. Have a wonderful summer.
Thank you.
Yes, I have lunch. Yeah.
So those are two different methods, right? For the other RNA, for the organism, for the
No, but we use the same to get the same method. I mean, bioinformatically we can determine that. The sample prep is the same.
You just extract
Total RNA.
Not needed to extract the mRNA from the.
No, it's total RNA. Yes. I mean, we can talk more. It'd be great. Yes. Awesome.
Can I just say one thing on the microphone? Excuse me. If anybody is interested in having a tour of BioInc, which is New York Medical College's incubator for startups, which is right in this building, I'm the director of the incubator and be so happy to show any of you around that are interested. So if so, just join me up here and I'll gather a group and lead a tour. Thank you.
Very intriguing. And some other conferences I attended that have had mucus in the gut being problematic. And with respect to stroke patients, the shunt rate of patients having stroke is over 20%. And certainly sepsis is one of the